Kính thưa các bạn, hôm nay chúng ta sẽ có những cái phiên, những cái bài rất là thú vị đến từ các cái chuyên gia đầu ngành về các lĩnh vực này. Đầu tiên thì tôi xin được giới thiệu bài báo cáo đầu tiên của cái phiên sáng nay là từ giáo sư Henry Ma, Đại học Monash, sẽ cập nhật những cái về điều trị tia sợi huyết đường tĩnh mạch cũng như lấy phối bằng đường cục dựa trên những cái chứng cứ mới nhất hiện nay. Ta biết rằng giáo sư Henry Ma có một cái nghiên cứu mà rất là nổi tiếng mà tất cả chúng ta đều biết, đó là nghiên cứu extend, đó là cho phép chúng ta sử dụng TPA đường tĩnh mạch với cửa sổ từ 4 giờ rưỡi đến 9 giờ. Tuy nhiên chúng ta phải cần có perfusion, chứng minh rằng những bệnh nhân này còn cái mismatch. Nghiên cứu này được công bố vào năm 2018 trên tạp chí The New England Journal of Medicine. Giáo sư Henry Ma cũng là người nghiên cứu rất là nhiều những cái thuốc về TPA thế thứ tư mới gần đây, đó là Tenecteplase, và sau đó là giáo sư Parson sẽ nói trong cái bài thứ hai rất là nhiều. Professor Henry Ma, can you start your
Thank
slide?
you. Thank you. Good morning, everyone. Sorry, I'm running a bit late due to the traffic issues and computer issues, but I'm glad that all sorted. So I'll try to go through a little bit quicker so that we can make up some time. And I've been asked to talk about update in thrombolysis from Thrombectomy. So there's a little bit of a mix and match here because there are a few interesting trials, but not a lot going on. But I try to pick up something that's interesting. I'll also try not to overlap with Mark, and also Bernard gave a talk yesterday too on thrombolysis and thrombectomy. So let's quickly go through thrombolysis. Mark will talk more about Tenecteplase. Let's just give a little very quick background to it. But I'm sure Mark will tell you a bit more about it. So this is the recent publications from the Canadian ACT trial looking at Tenecteplase versus TPA. This is a multi-center, open-labeled, parallel group registry-linked study. So within 4.5 hours, they used a 0.25 milligram per kilogram versus 0.9 of TPA. This patient were also eligible for thrombectomy. They were looking at non-inferiority, and towards the end of the talk, I will talk a bit more about non-inferiority margins. Anyway, they set it about 0.5. As you could see that in the red box, the baseline AHHS is, it's 9. It's not that severe. And the presence of large vessel occlusion, only about 24% of patients have large vessel occlusion in this cohort. As you can see, TNK is actually not, it's non-inferior to TPA. And the safety profile, looking at the hemorrhage down here, you can, go backwards. Down here, you can see the death within 90 days and 24-hour symptomatic hemorrhage are very similar to the alteplase group. So it was it's proven to be non-inferior by this trial. But then you look at the next trial, which is NORTEST 2, Part A, Phase 3. This is, again, an open-label, blinded and endpoint randomized trial within 4.5 hours of onset. The important thing is that, it's a 0.4 milligram per kilogram of TNK, not the 0.25. And the non-inferiority margin set at 0.3, but that really didn't matter because the fact that this trial was terminated early due to safety concerns. As you can see from the grotto bar here, that's Tenecteplase, and that's alteplase right down here. And you can see the MRS 0 to 1 is 32% in Tenecteplase and 51% in alteplase. And major neurological improvement, only 58% in Tenecteplase and alteplase 74%. But importantly, the intracranial hemorrhage is actually 21% versus 7%. And down here, symptomatic ICH is 6% versus 1%. So it is has significantly increased hemorrhage with no better functional outcome, hence it was terminated early. So I'm sure Mark will expand more about this. But this is the study that's done by Mark's group, and unfortunately part of this is TASTE A, where they put the Tenecteplase into the ambulance and using the dose of 0.25 milligram per kilogram. The primary outcome is not functional outcome, it's more of a perfusion lesion volume. As you can see, there's significant reductions of perfusion volume compared to alteplase in the Tenecteplase group. And there is a median perfusion volume of 12 versus 35 mils, and but there was no difference in clinical outcome and there was no safety concern. So that seems like 0.25, probably the right dose. But let's look at off-label use. I'm sure Mark will talk more about this. There's a lot of off-label use around the world on Tenecteplase, even though we're yet to wait for level 1 evidence and guideline changes. This is a meta-analysis of 6 studies looking at off-label use of Tenecteplase. And obviously, this is non-randomized data. As you can see, the Tenecteplase in this cohort, off-label use, probably had better successful recanalizations compared to alteplase and probably early neurological improvement, but not in excellent or good clinical outcome. So there was some signal there, probably better than alteplase, but this is off-label use. So it shows that it's been used quite a lot around the world already, even without the solid evidence at the moment. So I'll leave it at that for Tenecteplase. As I mentioned, Mark will talk more about it. Mark will also talk about, do we need more data? What we presented, is that enough? I reckon 0.25 milligram, probably the right dose. It probably overall is going to be a non-inferior rather than superior to TPA. That's my guess. But the more important to me is the safety profile. And even more important, it's already been used. I mean, people are kind of not really wanting the data anymore. They're already using it because of finance. It's cheaper and easier to use. So I think we have a lot of questions to think about. So as I mentioned, this is update. So I'm going to have a mishmash of little other trials here. This is thrombolysis in patients with acute ischemic stroke with large vessel occlusions. It's not much been trial around the world, and this is an interesting study of meta-analysis of 7 studies together, putting together. They basically shows using thrombolysis, it actually increased 2 times of increased odds of complete recanalization compared to alteplase alone in large vessel occlusion. There is no significant increase of intracranial hemorrhage nor functional changes. Hence, for this, we need a bit more data. I thought that's quite interesting to see. And then probably, I'm not sure how people know, there is another thrombolysis around the corner. I'm not sure. But this is a non-immunogenic recombinant streptokinase versus alteplase. So basically within 4.5 hour group, and moderate severe stroke at NIHSS of 11. It is again another non-inferiority set a pretty wide margin of 16%. That's a pretty wide margin. But anyway, the MRA 0 to 1 of 50% versus 41%. So they thought is the difference 9.5%, so it's non-inferior. But I think margin's pretty wide, but we'll wait and see where do they take this new thrombolysis agent. I just thought it's quite interesting. There are still people interested in the new thrombolysis agent in the era of thrombectomy. So let's talk about mechanical thrombectomy. What are the updates in mechanical thrombectomy? So this is just published in Aurora Studies in Lancet, putting the 6 major trials together of beyond 6 hours to 6 to 24 hours. And looking at the outcome. Basically, it's not an unexpected result we expect here. 6 to 24 hours from stroke onset, MRAs of exon 0 to 1 is 28 versus 12%. But interesting, if you look at the forest plot here, more than 80 years old, there is a, seems to be, there is a treatment effect here. But also, if you look at even the low aspect, there is probably a treatment effect here too. But obviously, this is further sub-analysis, but I thought that it was quite an interesting forest plot looking at the late time window and the subgroup cohort effect. So basically, it's proven thrombectomy is effective in a whole range of patients in the 6 to 24 hours time window. So this is just a late break. I think a lot of people may have gone to Singapore. Mr. Clean late, that was announced on the 27th of October, just a few days ago. The reason it did Mr. Clean late was because diffuse 3 and DON is quite complex, diffusion, clinical criteria. People thought, let's use a more pragmatic approach, basically using MRA or CTA with collateral circulations. The patient Mr. Clean late who fit the criteria of diffuse and DON were excluded. And basically the report at the WSC was that the MRS at 90 days was 1.7 times higher chance of better functional outcome in the thrombectomy group. But what's important thing is the demonstration of probably a more pragmatic approach without perfusion. You can still have good clinical outcome with thrombectomy. which is not unexpected, but I'll wait to see the full paper to have more details. So just looking at Mr. Clean-Late, they use collateral circulation as an assessment for patients for recruitment. But in fact, in Dawn trial, they actually look at their collateral circulation in the Dawn trial's patients. As you all know, Dawn trials patients were recruited within 6 to 24 hours. They assessed collateral circulation. Within the Dawn trial, the whole range from good to poor collateral circulations. But they found that patients with good collateral circulations, the MRS 0 to 2 was 43% versus 30% compared to the poor collateral circulations. And that kind of formed a bit of explanations for the positive result of Mr. Clean-Late, that collateral circulation may well play a part in the lifetime window of thrombectomy. So let's look at basilar artery thrombectomy. I think the other speaker yesterday probably spoke a lot more about it yesterday, so I'm not going to talk too much. But I think it's quite an interesting area to look at. So there are, as we all know, there are two major trials published on the same issues of New England Journal of Medicine, both from China. And let's look at the one on the left here, the tension one. That's within 12 hours stroke onset thrombectomy versus best medical care. TPA was actually given about a third of the patients, and MRS outcome of 0 to 3. Remember, this is 0 to 3, not the usual 0 to 2 or 0 to 1 in the anterior circulation thrombectomy trial. 46 versus 23%. Intracranial hemorrhage was increased at 5, and mortality was reduced at 37 versus 55%. And you can see the graph bar here, quite significant benefit. And similarly, in another trial, look at different time window. That was 12 hours to 6 to 24 hours. Again, outcome is 0 to 3. The recruitment of this one stopped early because of the effect. And so MRI 0 to 3, 46 versus 24%. Again, with raised intracranial hemorrhage, 6 versus 1%. And mortality of slight reduction of 31 compared to 42. Again, a very powerful effect, treatment effect from thrombectomy. So basically, to me, it's pretty clear that thrombectomy is effective for basilar artery occlusion. But interestingly, if we look at the forest plot here, but mind you that it is not powered to actually do subgroup analysis. So therefore, it's just a interesting, raise the interesting question and pointers. So if you look at both trials, what I put here, more than 80 years of age, they actually cross the midline here. And again, similarly, is a 0.93, also more than 70 years of age. So the older patients, the effect may be different to the younger patients. And also here, if we look at the proximal, middle, and distal here on the left, you can see the middle and the distal arteries actually again cross the midline. And similarly, here again, the middle and distal also cross the midline. So mainly the effect size came from the proximal occlusion. So obviously we need to have further analysis of the data and to see who are the groups that benefit more. But I think that forest spot is quite interesting. And actually they mirror quite well each other. So the other ones I want to talk about is medium vessel occlusion and also distal thrombectomy, because if you remember all the major trials from Hermes, they were all M1, proximal M2 and ICA, the proximal vessels. So what about the smaller vessels thrombectomy? So if you look at the Hermes back in 2016, again, you can see here the low aspect score across the midline and forest plot here, but M2 across the midline, and also milder stroke NIHSS less than 10 also across the midline. So these are the ones that we actually should, pay more attention to. Oops, the next one. Well, it's not changing. Okay, I think that's the next one. Yep. So this is a study looking at the clinical course of medium vessel occlusion with or without TPA. They basically look at M2 occlusion, and they found that about 1 in 2 patients do not achieve excellent outcome. But they do respond to TPA. As you can see from the bars here, a patient with a TPA or without TPA, there is a significant treatment effect. And TPA also helped to recanalize patients with medium vessel occlusions. And early recanalization by TPA in the medium vessel occlusion does correlate with good outcome. So yeah, they do respond to TPA. At what level and what effect we have to study a bit more. And this is also looking at distal neurovascular territory and looking at thrombectomy. Majority of these patients, more than 80% were M2, some were M3, very few ACA and PCA. And the achievement of MRS of 0 to 2 was achieving quite a significant numbers of 68%. That's pretty high, but a bit less for posterior distal vessels of 56%, only achieved 56% achieved 0 to 2. They found that in this cohort, the level of arterial occlusion is not associated with excellent outcome. So the level or the areas of the vessel occlusion wasn't really associated with clinical outcome. The distal anterior occlusion more likely to be functionally independent compared to posterior. So the anterior distal vessel occlusion did better than posterior and distal occlusions. And this outcome are quite compatible to large vessel occlusion in terms of thrombectomy. In fact, I thought it's actually quite good at 68%, achieving MRI 0 to 2. So this study particularly looked at the primary distal posterior cerebral artery occlusion, topmost studies. They look at thrombectomy in this PCA patients, nearly 200 patients of P2 and P3 thrombectomy. There was a reductions of NIHSS on discharge compared to standard treatment with thrombectomy, the mean difference about 1.5, and a treatment difference especially in subgroup with more severe stroke. If your NIHSS more than or equal to 10, the treatment effects was particularly larger, and on admission and patient who did not receive TPA. And again, there was a symptomatic intracranial hemorrhage rate about 4.3%. So in all, PCA thrombectomy potentially feasible, but not yet proven, and we definitely need more randomized control study looking at this particular area. So I think the medium vessel and distal vessels are very important questions to answer. There are quite a number of trials been running already, and myself and Professor Bernard Jans and Australian group are studying a frontier AP and an frontier AP posterior. So frontier AP is anterior distal version, distal thrombectomy, and frontier AP posterior is posterior distal thrombectomy. So we're hopefully starting this trial next year. We've somehow gotten this. Okay, so yes, so we're going to talk about bridging, but I just found this quite an interesting study published this year about bridging therapy for posterior circulations. All the bridging therapy we've been talking about been anterior circulations, but this is to talk about posterior circulation bridging therapy in basilar artery with IV-TPA plus mechanical thrombectomy versus mechanical thrombectomy alone. There are 3 studies put together, more than 1,000 patients. The bridging therapy actually did have better functional outcome and lower mortality compared to direct thrombectomy. So at least from this study, looking at basilar artery bridging therapy was better than direct therapy. As you can see, for mortality and MRI 0 to 2, both favor bridging therapy. So let's have a look at the large core thrombectomy. So I'm pretty sure people know about this Japanese study published this year in April. Within 6 hours of stroke onset or 24 hours if unknown time of onset using MRI flare mismatch. The results was quite significant stroke of NIHS of 22 with quite low aspect, only 3 to 4. So they're large strokes and basically ACM M1. The median infarct volume in the mechanical thrombectomy was 94 and 110 in the best medical therapy group. Only about less than a third of patients received IV-TPA, which is understandable because of a large core. I'm surprised someone gave IV-TPA in this sort of large core patients. A third of very brave people. MRI 0 to 3, remember we're always talking about MRI 0 to 2, but we're talking about 0 to 3 now. 31% in thrombectomy group and only 12% in the medical group. So these patients do very poorly. So only about 13% in the medical group achieve 0 to 3. And the early NIH changes was 31% and versus 88%. But there was increase in intracranial hemorrhage, as you would expect in large core, of 51% versus 34%, but not symptomatic. So any hemorrhage that was increased, symptomatic hemorrhage was not significant, although it was about 9 versus 4.9%. So it clearly shows that there is benefit, potential benefit of thrombectomy in large core patients. But this is a Japanese cohort, and they did use 0.6 milligram per kilogram of TPA compared to 0.9 pretty much everywhere else in the world. And there are other ongoing large core trials. So I think we need more evidence, particularly using 0.9 milligram per kilogram in terms of the safety profile. So looking at large core, the other problem about large core in the theory is bigger back and forth is if you give thrombectomy to large core, you reperfuse, it may lead to malignant edema because of a large core. And does it happen? So this study looking at the Hermes data, looking at patients with large infarction, which defined at 80 to 300 mils. So therefore, they actually found that despite the large infarction size, thrombectomy still improved outcome with an odds ratio of 2.3. Midline shift, interestingly, happened mainly around beyond 130 mil. So if you actually do your thrombectomy in less than 130 mil, so 80, 130 mil, the treatment did not seem to trigger off midline shift or cerebral edema. But beyond 130 mil, you start to have a problem. So that's a quite interesting observation. It will be interesting to see from future trials, does this stand up in terms of that, 130 mil, is it where a cutoff where benefits it's really not exist anymore? So I think that's a very interesting study to present today. So thrombectomy and age. So always we talk about is patient too old for thrombectomy. And I think there are quite a few local studies presented yesterday by some of the investigators and scientists here. It was quite interesting to look at age and thrombectomy. So this is using Mr. Clean registry data, comparing the young and the older people. So their definition of young, it's 18 to 49, so I'm old. The older group is 50. I think hopefully there's a lot of young people here, but that's an interesting definition. Anyway, so they dichotomized at 850. So within the registry, they found 10% young people. And the young people generally have lower NIHSS. The dissection as a diagnosis was actually 16%. The young people compared to the older people had better clinical outcomes with functional independence of 61 versus 39%. It's nearly a double. And mortality of 7 versus 32%. And intracranial hemorrhage also lower at 3 versus 6%. I think they're pretty much the same. The onset to reperfusion time of 253 versus 255. So young patients had better functional outcome, lower mortality, and less symptomatic hemorrhage compared to old people using Mr. Clean data. But then you use the Hermes data, looking at the very old now, we're looking at 85 years old plus receiving thrombectomy. They found 77 patients from the Hermes data, equal or more than 85 years of age, was associated with poorer outcome, high mortality, but they didn't find increase in intracranial hemorrhage. They particularly stated that patients of more than 85 years of age would still benefit if they're premorbidly, they were independently in functions. The odds ratios of benefit is 4.2. So they still benefit. As you can see down the table down here, there is a significant difference in terms of MRS 90 days, 0 to 2, 5 to 6, and mortality in comparing to the less than or more than 85 years of age. So I think that's quite interesting data looking at the young and the old people. So let's talk about direct thrombectomy versus bridging therapy. I think it all comes down to what we so-called non-inferiority. So I'm not going through the details of each trial. So it's too much. It's just the 6 of them, and we all heard and read each one of them. So I just quick summary slides about their outcomes and the margin. If you look at direct MT, it's less than 4.5 hours. The non-inferiority margin is 0.8. The DEVT is less than 4 hours and 10% non-inferiority margin. SKIP was a Japanese trial, non-inferiority margin 4.74. Misticline, no IV, was interesting. They were a test for superiority, but the conclusion was superiority not demonstrated. SWIFT direct was non-inferiority margin of 12%, and direct safe, which is Australian, and the ones also here is 10% non-inferiority margin. So you can see the non-inferiority margin is quite different. Compared to superiority, we all pretty much use p=0.05 p-value. And this is a mixed bag of non-inferiority margins here. And so this was just announced in WSC with the pool analysis of the 6 trials. And they basically concluded using a 5% non-inferiority margin that direct mechanical thrombectomy is not non-inferior to bridging therapy. That's the conclusion. And bridging therapy prior to mechanical thrombectomy had a higher chance of better functional outcome with higher chance of intracranial hemorrhage. So you got higher chance of intracranial hemorrhage with bridging therapy, but also better functional outcome. We need to see the actual full manuscript. So my conclusion for bridging therapy versus direct is, where do you set your non-inferiority margin? If it's very, very low, it's very easy to achieve non-inferiority. If it's very, very high, it's much harder to achieve non-inferiority. It depends on what you want and how stringent you want to be. We all have a p-value of 0.05, but I don't know anyone can agree on the non-inferiority margins. And I think doing more trials, it's not going to help here. It's about what we take home as we believe the non-inferiority margin should be. So lastly, interestingly, direct MT is one of them that actually showed to be non-inferior. They found that 15% have early reperfusion. If you give, they want to ask, if you're in bridging therapy, who are the patients that will respond to bridging therapy versus direct thrombectomy? They found that if the patients going to need thrombectomy waiting more than 33 minutes, the patient who had TPA was better off. Hence, it would make sense. You give TPA to open up a vessel while you're going for thrombectomy. So they found that the better functional outcomes was with patients who actually have randomized to growing time of more than 33% with bridging therapy. So mild stroke, I will quickly fly through this because as you saw before with Hermes, there was a question mark about NIHSS of less than 10. So these IV thrombolysis is patient with admissions NIHS of 0 to 1. This is Australian strict registry compared to 2 to 5. So 0 to 1 versus 2 to 5 NIHSS. Patient who had TPA with NIHS 0 to 1 had more early neurological deterioration, that lower rate of excellent functional outcome, and a higher rate of symptomatic ICH. These are the low NIHSS score mild stroke patients who are receiving TPA. And then you're looking at medical management versus mechanical thrombectomy for mild stroke. This is the meta-analysis. So thrombolysis in 41% of the best medical treatment group, both group has good collateral circulations. So they had more hemorrhage in the thrombectomy group, and they won a better functional outcome in the best medical therapy group. So 5 years, 16 centers with only NIHSS of 4. So you can see in this cohort, they had very good collateral circulation. I think this is about 80% of the patients, and occlusions were more proximal and 73% in the proximal area. So if you look at the best medical therapy, mechanical thrombectomy, MRS is 1 and 1. So they're very similar, and there is no statistical significance. So what about patients who have mild stroke clinically, but have a large vessel occlusion? Can we predict who are the patients going to get worse? So this is the prediction of early neurological deterioration in an individual with mild stroke and large vessel occlusion, intended for IV thrombolysis alone. So you think about giving TPA, but you worry about, oh, the patient probably will need thrombectomy or going to get worse. So finally, if you look at this trial, they define minor stroke as less than 5 NHSS. It's a retrospective cohort study. And they found that the patients who will deteriorate, have early neurological deteriorations, relates to the occlusion site. And the more proximal, understand the more likely they can deteriorate, and the longest thrombus length. The locations of the clot and the length of the clot may relate to the potential risk of further deterioration in minor stroke patient with large vessel occlusion. And if you look at this, again, using extend-IA data, the thrombectomy versus medical treatment in mild stroke due to large vessel occlusions, basically, again, similarly, the NHS is less than 6, the median is 4, and thrombectomy in mild stroke not associated with better outcome, but there was increased intracranial hemorrhage in this mild stroke patients. But the patient with target mismatch, thrombectomy was associated with better outcome. So we need perfusion imaging. So if you've got a mild stroke, large vessel occlusion, if you've got a large target mismatch on perfusion, you will respond. But on the other hand, if you actually don't have a target perfusion mismatch, meaning a penumbra, you're probably not going to respond it well and probably have more adverse outcome. So I think we need more details in studying this mild stroke, particularly perfusion. And then we're looking at bridging therapy in mild stroke. So there's a lot of trials actually happen. So this is a multi-center retrospective observational study with mild stroke of NHS less than 5, large vessel occlusions. They found that with actually large vessel better with bridging therapy. And you can see it favors IV-TPA as it becomes more and more distal. And the odds ratio moved that way so the more proximal, the more distal it is, the better response is just IV-TPA. So very much coming to the end of my talk, pre-stroke disability, we often think about, well, a patient with, some functional disability before reperfusion therapy, would they respond? So this is, again, looking using Hermes studies, looking at patients with pre-morbid or pre-stroke MRS 0 versus 1 and 2. So about 200 patients, and patients with MRS 1 and 2 had worse outcome compared to patients with no disability before, which is quite understandable. But it also shows that the benefit from thrombectomy is still observed despite the pre-stroke disability. So additional therapy, this is a choice trial looking at intra-arterial alteplase versus placebo after successful thrombectomy. They thought of using intra-arterial alteplase would help to reperfuse microcirculations. And there was an early termination of these studies. The 3-month MRS of 0 to 1 with excellent outcome was 59% versus 40% in the intra-arterial thrombolysis group. So we need further phase 3 studies on this. Interesting idea. It seems like there is a signal of response. On the other hand, Mr. Clean Med, looking at efficacy aspirin and unfractionated heparin, or both, or neither, during endovascular clot retrieval. And again, it was within 6 hours of onset, IV aspirin 300 or heparin 5,000 IU, followed by infusion for 6 hours, or low-dose heparin. There was no difference in functional outcome. And not unexpectedly, the patient who had aspirin versus no aspirin had an increase in symptomatic ICH of 14 versus 7%. Heparin group was also increasing symptomatic ICH of 13 versus 7%. So there was no benefit, functional benefit, but seems like increased intracranial hemorrhage. Then also rescue BT, I'm sure quite of you know about this, tirofiban versus placebo before endovascular thrombectomy. Again, hoping to reduce the risk of reocclusions and open up microvascular circulations. Unfortunately, there was no difference in functional outcome compared to placebo between the two groups, but there was increased intracranial pressure hemorrhage of 9.7 versus 6.4%. So unfortunately, Tara 5-MP4 thrombectomy didn't prove to be effective. So that's all. I'm sorry I'm rushing through. Thank you very much.
Thank you, Professor Helmer. With the presentation, update Thrombolysis and Thrombectomy về YouTube. Sau đây thì cái thời gian chúng ta cũng quá hơn 20 phút so với cái chương trình rồi. Thì chúng ta sẽ sang cái báo cáo thứ hai luôn. Tiếp theo cái báo cáo thứ hai là xin giới thiệu giáo sư Parson đến từ Australia với một cái báo cáo tiếp theo là về cái cập nhật những cái dữ liệu về cái Tenecteplase. Chúng ta sẽ tiếp tục theo dõi xem là cái Tenecteplase có cần thêm những dữ liệu gì, và từ cái báo cáo của giáo sư Helmer cũng đã đề cập rồi, thì bây giờ chúng ta sẽ tiếp tục theo dõi tiếp xem là cái Tenecteplase cần những dữ liệu gì nữa ở cái hai góc độ. Một là cái độ an toàn ở cái liều như thế nào, với liều 0.25 có phù hợp hay không, hay là cái mức độ là cái hồi phục chức năng so với Tenecteplase là như thế nào. Xin mời giáo sư Professor.
Thank you, and thanks for the invitation to Ho Chi Minh City, my first time here. It's great to be here. I'm going to start off with the rationale behind why we've been testing Tenecteplase, and you heard a lot from Professor Ma already, so I won't spend too much time on this, but if you go back and look at some of the studies looking at the effectiveness of intravenous alteplase for large vessel occlusion, you see that the rates of recanalization with so-called large vessel occlusion, which is what we call it now, are quite poor with TPA alone. And this led to motivation to test potentially more effective thrombolytics. And Tenecteplase is a very similar molecule to alteplase. It's got 3 molecular substitutions which may or may not make it a more effective thrombolytic. It's probably more fibrin specific, and that may lead to less systemic bleeding, but as Henry alluded to, I don't think the evidence is there that it causes less cerebral hemorrhage. However, because of the pharmacokinetic profile, we give it as a single bolus. You get more of the drug into the plasma and into the clot in the first 15 minutes after the bolus compared to intravenous TPA. So they're the theoretical benefits, and there's lots of studies now that have shown or compared Tenecteplase to alteplase, some randomized, some not. Predominantly phase 2 studies. Indeed, the only phase 3 study that's been published so far is NORTEST, which was with 0.4 milligram per kilogram, and I'll briefly comment on that. Luckily, I didn't put any slides on NORTEST 2 in because Henry's already covered that, and it probably doesn't deserve much more discussion because the investigators were told many years ago that they were using the wrong dose and they didn't listen. But I've learned over time, Craig, that when you tell people I told you so, they don't always take it so well. So this is going back 10 years ago. In 3 hospitals in Australia, we did a phase 2 study of Tenecteplase versus alteplase. So this was pre-thrombectomy. This study was published in 2012. So we recruited, I think, in between 2010 and 2012. And basically, we used perfusion imaging. In those days, we didn't have the pretty automated perfusion maps that we've got now. We just used the on-console vendor maps, and we basically used what we called at that time a dual target for selection, so an intracranial occlusion on CTA and the presence of penumbra with a relatively small core on perfusion CT. And for those of you who play golf, and it's pretty popular in Vietnam, I notice, and we thought we found the sweet spot, so patients with an occlusion, a small core and a large penumbra. It looked like this group of patients had more effective early reperfusion with Tenecteplase compared to alteplase, and also a parallel improvement in NIH score at 24 hours. So, and we looked at 2 doses of Tenecteplase at that time. It wasn't really clear what the right dose was. I should go back and say, for those of you who are not familiar, the cardiac dose of Tenecteplase for myocardial infarction is a touch over 0.5 milligram per kilogram. Some very early, an early American study by Clark Haley Jr. in Virginia showed that the 0.5 dose cause too much hemorrhage in stroke. So we really weren't sure if it was 0.1, 0.25 or 0.4 milligram per kilogram. So in the early days, we started with the two lowest doses, and the 0.1 milligram per kilogram dose was more or less equivalent to alteplase in terms of recanalization, but the 0.25 milligram dose was considerably superior in this study. So just in comparison, if you look at the Extend-IA study, which was one of the endovascular studies that Henry showed, and compare the reperfusion rates at 24 hours, our early T&K trial was predominantly M1 occlusions with a few carotid occlusions, and the rates of 24-hour reperfusion with Tenecteplase were not dissimilar to clot retrieval, but bearing in mind this is at 24 hours, and I'll show you some early reperfusion data later on with some later work. Thank you, Henry, for showing the TASTE-A study that we recently completed, and this was an example of great teamwork. So the Melbourne Mobile Stroke Unit is housed at Royal Melbourne Hospital, but delivers and picks up patients from all over Melbourne, including Henry's Hospital, Monash Medical Centre, which is in the southeast and is quite a long way from Royal Melbourne Hospital. So we had I think 5 hospitals involved, so Monash, Royal Melbourne, Alfred, Box Hill and the Austin. So that's why, a lot of the authors are paramedics and all of the fellows that worked on the stroke ambulance. And when I presented this in Lyon, I was a bit embarrassed because I said this was the first study that I've actually led that I've not recruited one patient into. However, I had a good excuse for that, because just after the study started, I had a cardiac arrest and was off work for 6 months. So, but we actually recruited 104 patients in less than a year. So the Melbourne Mobile Stroke Unit actually sees quite a lot of patients. So we actually recruited very quickly compared to, I guess, in-hospital studies for a single centre. Now that's just a map of Melbourne, which I won't bore you too much with, but there's some of the hospitals that were involved. And as Henry said, there was a slight limitation to this study, which Henry was kind enough not to mention, but I'll mention it. So the primary outcome, this was a phase 2 study, patients with that were deemed thrombolysis eligible on the stroke ambulance. So had a CT scan and a CTA on the stroke ambulance, non-con CTA. If they had no hemorrhage and they were thought to be thrombolysis eligible, they were enrolled into the study, received alteplase or Tenecteplase 0.25 milligrams per kilogram. And the primary outcome was actually the size of the perfusion lesion in the emergency department when the patients arrived at whichever hospital they were delivered to. So the perfusion lesion was after treatment. So we don't have a pre-treatment perfusion lesion because most stroke ambulances, including the Melbourne one, don't have perfusion capability on board. We can talk more about that in the next talk if you like, when I talk about pre-hospital. But interestingly enough, the groups were quite well balanced. There are actually quite a lot of large vessel occlusion patients. In fact, if you look at the baseline large vessel occlusion, which we detected on CTA, and mind you, the CTA on the MSU CT scan is not the highest of quality, so you often won't pick an M2 occlusion. So these are predominantly M1 and terminal ICA occlusions, but you can see almost 50% in the TNK group had an LVO compared to 40% in the TPA group. So you might say that actually biased against TNK having a better effect. But the primary outcome was the size of the perfusion lesion, and there was a pretty big difference in the perfusion lesion on hospital arrival. And this was the CT was done on average about 50 minutes from thrombolysis afterwards. So it's still pretty close. And to parallel that, there was also a significant difference in early NIH reduction. This is really early. So this is NIH score pre-treatment on the MSU compared to NIH score post-treatment in the ED, again at a median of just under an hour. You can see that there wasn't a very large change in the unarmed stroke score, but the TNK group had a larger proportion of patients with a significant reduction, which was statistically significant. I think the other pointer that was pretty clear was that the time from CT scan on the MSU to initial bolus of lytic was 7 minutes faster with Tenecteplase, and you realise why that is, because it takes a little while to prepare the TPA infusion. So it's much quicker just to bang in the bolus, whereas if you've got TPA, the nurse is on preparing the infusion and there's often a bit of delay. So that was just, I guess, a practical thing of interest. The study wasn't powered to show a 3-month MRS difference, even though there was a trend. But there certainly looked to be evidence that Tenecteplase might be more effective very early on. But again, that was another phase 2 study, and I think we've probably been overly swayed by all of these very attractive phase 2 studies. Some of them are mine and Henry's and Bruce Campbell's, and perhaps we've been too convincing in telling you how great Tenecteplase is. But as Henry alluded to, there's still no level 1 evidence that Tenecteplase is equivalent to alteplase, let alone superior. And again, I'll declare a conflict of interest. I think we need phase 3 trials, and I'll talk to you about a couple that we're running now, and one that we'll be running in Vietnam soon with Dr. Nguyen in Ho Chi Minh City. And I'm glad Henry talked about the ACT study and non-inferiority, and we've got the world expert in non-inferiority trials sitting in the front row, Professor Anderson. He might like to comment later. But it's very clear that, as Henry alluded to, non-inferiority doesn't mean equivalence. And Henry actually showed a slide that said with direct MT was not non-inferior. That's a double negative. So it's quite a complicated area. And one thing that I wanted to comment on, which Henry will appreciate, in some countries, the active researchers are not allowed to be on guideline committees. In Australia, they are. And if you can show that you're changing guidelines, you get more funding to do your research. There's a significant conflict of interest. And the Australian guidelines changed very early to recommend Tenecteplase for stroke. And I still think that they were changed prematurely. However, and we actually wrote an editorial about this in the Medical Journal of Australia 2 years ago, warning that we were switching too early. People were using the COVID pandemic as an excuse to switch to Tenecteplase. I still don't quite understand what the connection between COVID and Tenecteplase and stroke was, but people used it as an excuse. And we predicted 2 years ago that if we kept using Tenecteplase off-label for stroke, due to the fact that Boehringer weren't increasing production, we would run out of Tenecteplase, and that's exactly what's happened in Australia and in many other countries. Indeed, alteplase is in short supply too. We coined I thought the editors would take this out of the article, but I mentioned that it was premature translation, and that's my analogy with Tenecteplase and TPA. I think we've gotten a bit overexcited with the phase 2 evidence. And a bit more on the ACT trial. Yes, the ACT trial did show non-inferiority at I think it was a 5% margin, Henry. And it's interesting because we looked at exactly the same meta-analysis to calculate our non-inferiority margin for our phase 3 trial, TASTE, and we've come up with a 3% non-inferiority margin, and I won't bore you why, but 5% is pretty generous. Now, if you look carefully at the results of ACT, yes, there's an absolute benefit of Tenecteplase compared to alteplase in the entire patient group of around 2%. But if you look carefully at the confidence intervals, they go as low as minus 2.6. So there's still a considerable chance that Tenecteplase might be inferior to alteplase based on that data. And this is for you, Craig. The ACT trial, and the NORTEST trial for that matter, didn't have a positive imaging diagnosis of stroke. The ACT trial had 25% of patients that had a CTA occlusion. So 75% of patients in ACT had no vessel occlusion and they didn't do perfusion. So this is my link into here. So this is a functional neurological disorder, and this is how Professor Anderson checks if it's functional or not. This patient's got a functional paraparesis. I don't know if you've seen the movie. That's Talladega Nights with Will Ferrell. But this is just a segue into the fact that NORTEST and ACT had probably included quite a lot of patients with stroke mimic, and we don't know how many. So NORTEST used 0.4, that was the initial trial, and showed no difference. But you can see that the stroke severity was very low, NIH less than 7. And they actually said up to 20% of their patients had a stroke mimic. Now, ACT could well be exactly the same. So Henry showed you the data. It looks certainly that in patients with an occlusion, a large vessel occlusion, that there was certainly a trend towards to benefit in Tenecteplase, but definitely wasn't proven. And if you look at the group without an occlusion, and there may well be a lot of stroke mimics in that group, there was absolutely no difference between Tenecteplase or ortoplase. So in fact, ACT actually showed that TNK might be non-inferior to TPA for stroke mimics. So what do we really need to switch to Tenecteplase? We need phase 3 design trials where all patients enrolled actually have a proven diagnosis of stroke. And that's both non-LVO and LVO. So this is the study that we're a long way down the track to completing, but for various reasons we've had, it's been quite slow. And when we designed this study, TASTE, this was pre-thrombectomy, so we were banking on getting a lot of large vessel occlusions in this study. Unfortunately, we started in 2014 and then all of the thrombectomy trials came out in 2015. So this study has now become predominantly a non-LVO trial because we originally said we're not going to include thrombectomy patients because we wanted to see the effect of Tenecteplase versus ortoplase without the contaminating effect of thrombectomy, which is a very powerful treatment. And we're using predominantly perfusion CT. We do allow perfusion MR, but none of our centres are using it. And basically patients in the 4.5-hour window with perfusion core mismatch on CT are enrolled. We've had a few changes along the way because we recognised that we were not getting many M1 occlusions due to the thrombectomy introduction. We changed to a non-inferiority design because it's going to be nearly impossible to show that Tenecteplase is superior to ortoplase in more distal occlusions, even if it is. We need many thousand patients to show that. And we changed to an adaptive sample size estimation, and at 546 patients, we looked the blinded DSMB looked at the data and says the final number we need is 832. We're currently up to 617. Obviously, COVID really slowed us down as well. You can see from the baseline characteristics that it's a relatively mild stroke population, but at least we know they're real strokes because they all have a perfusion lesion that you can actually measure and see on the table. We're multi-centre. We've got over 30 centres worldwide. John Hunter, which is where the study started in Newcastle, where I was previously, has enrolled most patients. Box Hill's a very busy primary stroke centre in northeastern Melbourne. And then we've got Royal Melbourne, Royal Adelaide, Liverpool, which is where I am in Sydney. You can see Addenbrooke's at Cambridge, a couple of our Taiwanese colleague centres at China Medical University and Tri-Services General are good recruiters. Carlos Molina's group, and then we've got a few. Henry's there somewhere, Monash, but we're hoping to bring on 4 or 5 centres from Vietnam very soon, thanks to Dr. Nguyen. And hopefully that will help us finish the trial. We've actually got a quarantine clinical trial supply of Tenecteplase, which is not allowed to be used for commercial use. Otherwise, we wouldn't be able to complete the trial because in Australia, we've been told we can't give Tenecteplase for stroke for clinical practice. And then just moving on to LVO and upcoming trials. You've all seen the phase 2 study, Extendo-18K, where patients with LVO were randomised to IV Tenecteplase or IV-rTPA. The primary outcome was reperfusion on baseline angiogram. And you all would recall that 200 patients in each arm, mostly M1s. There was considerably more TICI-2B and above reperfusion in the Tenecteplase group compared to rTPA. Sorry about that. That formatting's gone funny, but you can see the table. That was a significant improvement, and there was a Rankin shift as well for what that's worth. The study wasn't powered to look at 3-month outcomes, so I don't really know how much we can take out of that. But that's another phase 2 study, and yes, it looks very pretty. It's not enough to change practice. So there, we're also doing a phase 3 trial of LVO stroke with Tenecteplase, and I should say that the name Eternal may be a little bit is a little bit like the American study called Timeless, which is also looking at Tenecteplase pre-thrombectomy versus placebo. That'll, I think, be published and presented at ESOC next year, I'm told. We started a bit later, and again, we've been hampered by COVID and other factors and the lack of Tenecteplase. So at the moment, we've only started the study in a few Australian centres, but in 1 year, we've actually recruited, 18 months, we've recruited 200 patients. So this is a 0 to 24-hour study. It's in patients with LVO. They get randomised to Tenecteplase or standard of care, and in standard of care, you can choose rTPA or not, depending on your preferences. So as it turns out, about half of the patients that have been randomised are in the sub 4.5-hour window. So the patients in standard of care have all received rTPA. So we've actually got, this will be the largest study of Tenecteplase versus rTPA in LVO, sub 4.5 hours as well. Hopefully we might be able to bring that to Vietnam too when we sort out our Tenecteplase issue. I can't say too much, but we will probably get a supply of Tenecteplase from somewhere in the next 3 months. I can't tell you which country yet, but we'll see. And I think that's my last slide. So I'm in southwestern Sydney now, and I might say, I'll tell you in our next talk, but in southwestern Sydney, we actually have a very large Vietnamese population. About 25% of the patients that come to my hospital are of Vietnamese background, and that's some of the team. And we work very closely still with our Melbourne colleagues, so we have a big collaborative group that works across the cities. Thanks very much.
Thank you, Professor Max Parson. Tiếp theo thì tôi xin giới thiệu giáo sư Henning Christoph đến từ Đức, với cái trình bày về cái sử dụng kháng đông sau đột quỵ cấp cũng như là xuất huyết não. Thì cái này là một cái chủ đề cũng khá là hay, và tiếp theo khi sau cái phiên này thì có 10 giờ đến 11 giờ thì chúng ta có một cái cũng là về cái chủ đề này. Quý vị đồng nghiệp chúng ta đón nghe và theo dõi. Ngày hôm qua bên hội trường B thì chúng ta cũng có một cái topic về cái lĩnh vực này, nhưng mà trong cái thực hành lâm sàng thì liên tục đặt ra những cái thách thức mà khi nào chúng ta sử dụng cái thuốc kháng đông, đặc biệt là các cái bệnh nhân mà có nguy cơ cao, đúng không ạ? Thì nó rất cần nhiều những cái dữ liệu, những cái nghiên cứu để quý vị đồng nghiệp có thể tham khảo thêm.
So good morning. Whenever I try to give a talk here, there's obviously a technical problem, and the slides don't move, by the way, which makes it even more difficult. So I realized that almost all of the invited speakers are from Australia or Hong Kong. So I'm the only exception, but I worked some time in Australia, so I consider myself 10% Australian. And you see, I no longer treat patients. I'm retired. I'm very old. And now I head the Department of Neuroepidemiology, which means I still do studies, but I don't see patients anymore. Okay, it's working. Good. This is my conflict of interest slide. You have seen it already. I would like to start with the case. This is a 75-year-old man who was admitted to hospital with an acute ischemic stroke. He has a history of atrial fibrillation, hypertension, peripheral vascular disease. He was a smoker for most of his life, and he has a history of poor adherence to anticoagulation in the past. And this is a major problem with anticoagulation, in particular with warfarin, that many patients are not really adherent. The stroke was not very severe, NIH score of 8, and now he is about to be discharged home with minimal impairment, and his question is, what should I do now? When should we resume anticoagulation? Should we still use warfarin? This case was 5 years ago, where they had a choice. Nowadays, they don't have a choice because everyone gets a NOAC. And at what time should the anticoagulation be initiated? And remember, this is always a benefit risk we have to consider if we look at these people. We want to minimize the risk of an early recurrent stroke and recurrent stroke, but we also have the risk of hemorrhage into the brain, into the ischemic area, if we start anticoagulation too early. And this is what we have to balance, is benefit preventing recurrent stroke and risk, which is hemorrhagic transformation or bleeding into the ischemic areas. So what are the guidelines saying about the initiation of anticoagulation? The American guidelines say basically you can start within the first 2 weeks. And this is totally useless. And this is why you would listen to the European guidelines, because they follow my advice, which is Diener's law, as you know. And as a general remark, usually it makes much more sense to follow the European guidelines than the US guidelines. Good. How does this work? These are the ERA guidelines, which I was part of. And the ERA guidelines say you have an acute ischemic stroke, you do brain imaging, and if the patient has no hemorrhagic transformation and no bleeding, you can initiate all anticoagulation. And the timing is the following. If someone had a TIA and has normal brain imaging, you start immediately. If someone had a TIA and has ischemic lesions, which no longer is a TIA because this is by definition a stroke, then the patient is stable, you start within 1 to 3 days. And if the patient has a mild neurological deficit and a small lesion on imaging, you start within 3 days. And if a patient has a moderate neurological deficit, a medium-sized lesion, then you have to repeat the imaging to exclude hemorrhagic transformation. If there is no hemorrhagic transformation, you can start usually within a week. And if a patient has a severe neurological deficit, again, you have to repeat the brain imaging, and then you can start at about 12 days. At that time, remember, when we wrote these recommendations, there was no evidence. So this is eminence-based. The eminence is me. What's about people who have hemorrhagic transformation? You wait until they are stable, until they improve clinically. Then you repeat the CT scan, and if the blood has disappeared, you initiate anticoagulation. So this is what we recommended about 2.5 years ago. But we have ongoing trials, and one is just published, the timing study. And the timing study compared in people with mild strokes, not severe strokes, initiation of anticoagulation between day 1 and 4 and day 5 to 10, 888 patients. Excuse me. And then we have ongoing the START trial, and they compare day 3 versus day 6 and 10 days, day 10 to day 14. We have the optimal trial, which has early 1 to 4 days and then by 7 to 14 days, and the ELAN trial. And the ELAN trial makes it dependent on the severity of stroke. So if it's minor stroke, you can start within 48 hours and so on. So, but we only have the results of the timing study. So again, to remind you, timing had patients with acute ischemic stroke, mostly mild strokes, and they were randomized to early NOAC treatment, no warfarin, only NOACs within 4 days, or between 5 and 10 days. And the primary composite endpoint was recurrent ischemic stroke and symptomatic intracranial hemorrhage and mortality. Now here you see the problem. The problem is always if you mix efficacy, which is preventing recurrent stroke, with safety, which is bleeding into the brain. And we always have this discussion with EMA and with the American agency because they want to have the overall picture, but we would rather have different endpoints, one efficacy endpoint and one safety endpoint. And this was published, as you know, recently, a randomized trial in Sweden, patients with ischemic stroke, as I said, and this was the result. So if patients were treated early, the primary endpoint was less frequent, and you see the risk reduction is 22%. This, unfortunately, was not significant, but there was a strong trend. And this would mean that early anticoagulation most probably is safe, and so at least in people with mild and a few with moderate strokes, you can initiate anticoagulation within 4 days. Excuse me. And there is also a registry, which is a SITS registry, which is worldwide a registry, as you know, of Alteplase all over the world. But they also looked at this, when are physicians starting the bigatran after an ischemic stroke? And if you look at the distribution here, you can see the majority of physicians would start anticoagulation between day 3 and 2 weeks. And the most common reasons for delaying the initiation of anticoagulation was the severity of stroke, whether the stroke was small or large, and whether patients had hemorrhagic transformation. And this is your clinical decision. You look how severe is the stroke, how big is the lesion, is there hemorrhagic transformation, very straightforward. And CPAS was also a multi-center prospective investigator-initiated study, again with the bigatran, initiation within 14 days in people with TIA or minor ischemic strokes. And if you look at the cumulative initiation of anticoagulation, you can see the majority of patients is anticoagulated within 7 days. And what they basically observed is that hemorrhagic transformation was the most frequent reason why the initiation of anticoagulation was delayed beyond the first 7 days. And we had a 10,000 patient registry in my country. When we started this 4 years ago, I tried to convince the sponsor to have a randomized trial, but unfortunately the sponsor was not willing to fund a randomized trial. And then I approached the German Research Council, and the Research Council said the company should pay for it. We are not paying. I think it was a big mistake. I would have liked to have a randomized trial. And though this is an observational study, it's the inclusion criteria where people had atrial fibrillation, and you had to have consent, and people had a TIA or ischemic stroke, all severities of ischemic stroke. And so we observed these patients until hospital discharge, and then again prospectively for 90 days. And we had a central follow-up after 90 days with usually telephone interviews, or patients came back to the treating stroke unit. Then the primary endpoint, this was a safety study, was major bleeding within 3 months. And secondary endpoints were recurrent ischemic stroke, for example, or a composite endpoint of ischemic events and major bleeding. And we wanted to compare the early initiation of the bigatran, which is less than 7 days, with the late initiation. And then we also compared initiation with the bigatran, with the 10A inhibitors, and people who were not anticoagulated, and people who, for example, received antiplatelet therapy. Now, if you look at the event rates per 10,000 person days, if the bigatran was initiated early, and you look at the primary endpoint, which is major hemorrhage, it was 2.3. If the initiation was delayed, it was 1.8. If we pool the two bigatran groups, it was 2.2. And if we look at vitamin K antagonists, it was almost 5. So this tells you that if you initiate, and this was corrected for all kind of baseline parameters you can imagine, warfarin has a higher risk of bleeding despite the fact that it takes longer until it becomes effective. Remember, the bigatran works immediately within 12 hours. Warfarin, it takes about 5 to 7 days until it's fully active. And you have clearly a higher rate of bleeding. There was no difference in ischemic stroke. You wouldn't expect a difference in ischemic stroke. And there was also no difference in the composite endpoint. So we calculated odds ratios or hazard ratios, and the hazard ratio for the bigatran versus vitamin K antagonist was 0.752 for major hemorrhage. This means the risk of major bleeding, including intracranial hemorrhage, was 50% lower when you initiate with the bigatran compared to warfarin. By the way, similar results for apixaban, rivaroxaban, and edoxaban, and I didn't show you the results. So what we learned from this study, number one, people delayed the initiation of all anticoagulation beyond 7 days in patients who had a severe stroke and patients who had hemorrhagic transformation. Now let me come to the second part of my talk, and this is the initiation or resumption of anticoagulation in someone who had an intracerebral bleed. This patient, as you can see, has a basal ganglia bleeding. The patient has atrial fibrillation. He was treated with warfarin, and he has diabetes. And at admission, his INR was 5, which tells you why he had the bleeding, because he was not very well controlled on warfarin. And this is in secondary stroke prevention, the European guidelines, and this is what I wrote into the guidelines, is after intracranial hemorrhage, all anticoagulation in patients with AF may be reinitiated after 4 to 8 weeks, provided the cause of bleeding or the relevant risk factors have been treated or controlled. And most probably, this is too long. Most probably, most patients can be anticoagulated after 4 weeks. And then we looked at the literature and what are factors that would encourage you to start to withhold oral anticoagulation or initiate late. And this is bleeding occurring on an adequate dose of either a NOAC or warfarin. Or if someone is above 75 years, in particular, you shouldn't resume anticoagulation if blood pressure is not controlled. And if someone has a cortical bleed, has many, many microbleeds, 80, 100, I don't know how many. And then if you cannot remove the cause of bleeding, for example, there is an AV malformation which cannot be treated. And if a patient needs dual antiplatelet therapy, has atrial fibrillation, has a recent stent, and in these patients, you have to wait until the dual antiplatelet therapy is changed to monotherapy. And then the other way around, if someone is younger, you can start earlier. Now you have to consider the type of intracranial hemorrhage. This is, as you in the RELY trial, 46% of people on either warfarin or the bigatran had an intracerebral bleed, 8% had a subarachnoidal bleed, and 45% had a subdural hematoma. I remember one particular patient here in Canada. He had this subdural hematoma and he was successfully operated. And so he called the monitor 2 months later and said, you know, the cause of my bleeding was that my wife hit me with a bottle on the head and I want to go back into the study. I resolved the problem. I got divorced in the meantime. So again, ERA practical guide about the initiation or resumption of anticoagulation in people who had a cerebral bleed. Here. So as I said, if you could not identify the site of bleeding, for example, there is a high risk of bleeding into the GI tract. If someone has chronic alcohol abuse, if someone is old, then you have to consider that you can no longer anticoagulate, but there is an option. in people who have a contraindication for long-term anticoagulation, and this is occlusion of the left atrial appendage. And we have ongoing trials, 3 of them, one in Europe, one in the United States, and one worldwide, who look at this. And the recruitment is already advanced, so most probably in 2 years, we will have evidence whether LAA occlusion is really feasible. Now, there is another question is, can you reinitiate antiplatelet therapy in someone who had an intracranial hemorrhage, not atrial fibrillation, on antiplatelet therapy? And this was the RESTART trial. And the RESTART trial was really a surprise because it showed not only that you can initiate antiplatelet therapy again, but that patients on antiplatelets did better than patients where antiplatelet therapy was not resumed. This was really a surprise, a positive trend. So let me summarize. We have unfortunately only one randomized trial, which is timing, which tells us when to initiate anticoagulation in people with AF who had an ischemic stroke. And until we have more evidence and it gets more granular on which day should I really start in which patients, we have to wait until we get the results from the other trials. And what we learned from our 10,000 patient registry was that at least the bigatran and the 10A inhibitors are safer than warfarin when you initiate them after an ischemic stroke. And for people with cerebral bleeding, you have to consider carefully the risk of a recurrent bleeding when you decide whether you can restart or resume or start anticoagulation after cerebral bleed or subdural hematoma or subarachnoid hemorrhage. Thank you very much.
Thank you, Professor Diener. Trong khi chờ đợi các bạn có khoảng từ 1 đến tối đa là 2 câu hỏi cho cái phiên này, tôi xin được nhắc các bạn, tại vì chúng ta sẽ có cái phiên thảo luận về kháng đông sau, nên là ưu tiên các bạn sẽ hỏi đến 2 speaker về Henry Ma hoặc là Mark Parson. Ở đây tôi xin được trả lời trước online trong khi các bạn chuẩn bị câu hỏi. Đấy là một bạn hỏi trên online là một bệnh nhân can thiệp bằng dụng cụ, tuy nhiên thời gian làm thủ thuật kéo dài. Ví dụ thời điểm tham khởi phát đến lúc tái thông là 12 giờ thì có làm tăng các biến chứng cũng như kết cục xấu hay không? Điều đó chắc chắn rồi, đúng không ạ? Vì chúng ta kéo dài cái thời gian tái thông, tuy nhiên là chắc chắn. Thông thường các bác sĩ can thiệp người ta chúng tôi thường người ta chỉ cho phép làm khoảng tối đa 5 pass thôi, tức là kéo khoảng 5 lần hoặc 6 lần, chúng ta không thể kéo hoài được, và kéo hoài nó sẽ gây tổn thương mạch máu. Please, Professor.
Well, good morning, everyone. Craig Anderson from Australia. All great talks, and I've got 2 questions, if I may, but I guess it is directed to Professor Diener, but others could make a comment. So the first one is a bit more specific. You put a lot of weight on blood and the CT, and, you know, as clinicians, we worry about blood. But, you know, the bleeding in the brain stops very quickly. It's just blood sitting there. And I wonder why you worry so much about causing more hemorrhage when the hemorrhage is resolved within hours. That's the first question, and I'll come back to a second question.
Very important question. I'm really sorry because I didn't mention. The reason to delay are people who have hemorrhagic transformation and clinical worsening. So if someone only has a little bit blood on the CT and is stable, this is not a contraindication to start anticoagulation. But it's different if someone has a worsening or you have a clear hemorrhage and not a little bit of blood on the CT.
And then the second question, which is methodological, because we're all trialists here and be interesting for everybody to have an opinion, is that these nuances around benefits and risks, they're really tricky. And it's the way forward, because I think now we're looking at how to be more precise about targeting our therapy. We're getting into precision medicine. And so are we going to do the conventional way, which is one trial at a time, and take ourselves another 20 years to get the answer, which is we hypothesize a very carefully defined subgroup and study that very clearly? Or do we do a more pragmatic type of trial, which you're familiar with, where we just include as many people as possible and focus on the subgroups? You know, it's a cross-Atlantic philosophical thing in terms of whether you go for something very targeted and specific, take us 5 or 6 years, spend a few $1 million or more on doing it, and we might get it right or we might not, or whether we just take a more real-life pragmatic approach. I know it's philosophical, but I'd be interested to hear what people think.
Yeah, perhaps I can answer it. We submitted a pragmatic trial to the German Research Council with a 1-page CRF. And we wanted to test in people who have atrial fibrillation and atherosclerosis of any kind, pulmonary, peripheral, carotid arteries, intracranial, whether we should combine antiplatelet with any anticoagulant versus anticoagulant monotherapy. And the reviewer said, this is not the adequate way to do a trial because, you know, you are missing A, B, C, and D, and so I turned it down. And I was really angry because I wanted to do this trial within 18 months. You know, your approach, have many patients, and then you can correct statistically for major problems. Because if you have 15,000 patients or 10,000 patients, most problems go away just by numbers. But they turned it down, so we couldn't do the trial. But I would have preferred to have it simple, quick, 1 question, period. Yeah, thanks.
Ở đây tôi xin được tóm tắt một chút. Có 2 cái điểm mà chúng ta ghi nhận trong cái bài của ông Henry Ma đó, vừa cập nhật ở cái hội nghị đột quỵ thế giới ở Singapore. Thứ nhất, đó là một cái nghiên cứu mà chúng ta có thể lấy huyết khối bằng dụng cụ học ở những cái ca mà lõi lớn. Mặc dù cái nghiên cứu này nó vẫn còn một số những cái điểm mà chúng ta cần xem kỹ lại, nhưng mà nó đã cho phép chúng ta làm lấy huyết khối trên những lõi lớn với expect là từ 3 đến 4 điểm. Anh chị nhớ rằng trước đây những expect khoảng chừng 5 điểm, 6 điểm chúng ta đã bỏ rồi. Thì trong cái nghiên cứu này, cái expect từ 3 điểm đến 5 điểm vẫn được lấy huyết khối và vẫn được chứng minh rằng tốt hơn so với việc chúng ta không làm gì cả. Một nghiên cứu thứ hai cũng được công bố vừa đây, đó là nghiên cứu Mr. Clean Lake, tức là nghiên cứu đó cho phép chúng ta lấy huyết khối ở cơ sổ từ 6 đến 24 giờ và không cần perfusion, chỉ cần CT-CTA, tức là đánh giá cái tuần hoàn phụ và cộng với cái lõi trên CT scan thông thường. Như vậy các anh chị thấy rằng vai trò của CT scan ngày càng lớn, không chỉ trong cửa sổ thường quy mà ngay cả cửa sổ từ 6 đến 24 giờ chúng ta vẫn có thể dùng CT-CTA để chúng ta quyết định lấy khối dụng cụ với cái Mr. Clean Lake. Đó là cái mà chúng tôi đã sử dụng trước khi thời điểm chúng tôi đã có Rapid. Please, Dr. Penachan.
I just like to ask maybe 2 questions with Mark and Henry about Tenecteplase. I think the ACT trial is pretty well done. The inferiority margin is pretty narrow and decent size. So is it already adequate for approval from the drug regulatory standpoint, although there's some concerns about the margins and so on, but we don't want to prove superiority. We just want to prove inferiority, or at least in Canada where the trial is done. This is one question. And the other question is, TNK at 0.25 milligram per kilogram, I think it's pretty convincing for large vessel occlusion. But if it's good for large vessel occlusion, whether it's a little bit too much for the mild stroke and the couldn't stroke. And on the ACT trial, if you look at the numbers, it's slightly more symptomatic ICH in the whole population. And in some regulatory authorities, I think in India, they use 0.2 milligrams, slightly lower dose, whether there needs to be some additional investigations of the lacunar strokes or other strokes. Okay, thank you.
Thanks, Bernard. The ACT trial won't get Tenecteplase registered in any jurisdiction except apart from Canada. There'll need to be a proper phase 3 trial to go along with it. So a test 2 is the big, very pragmatic, going back to Craig's point, Tenecteplase versus alteplase trial in patients with basically a clinical diagnosis of stroke. That will probably finish sometime next year. If that shows non-inferiority, that will possibly be enough to get a license for Tenecteplase. I agree with you about the hemorrhage point, and I see all of the serious adverse events in our TASTE trial, and I can't say too much, but it certainly doesn't look like there's less hemorrhage in one group compared to the other, symptomatic hemorrhage, and that's in predominantly distal occlusion. Then we get into the vexed question of distal occlusions and lacuna stroke. I would argue that we still don't actually have good evidence that alteplase is superior to placebo for some of those patients, and I guess that's where you might actually look at what Craig was alluding to. The future of clinical trials is not going to be single one question trials, but perhaps a larger registry-based or platform trial where you recruit lots of patients and you can ask multiple questions in the same cohort or registry. And there might well be potential for looking at different doses of Tenecteplase. For example, our first study way back in 2005 was with 0.1 milligram kilogram of Tenecteplase, and that was in patients with more distal occlusion. So I think there's certainly scope for that. But it won't get registered based on ACT, Tenecteplase.
Hey, I see in your slide, you say no inferior is not mean equivalent, right? It's a very confusing term in Vietnam.
It's confusing.
Yeah, it's very confusing.
It's confusing in English too.
In Việt Nam các anh chị hay dịch là no inferior là ngang bằng, no inferior là không thể bằng.
Maybe it's
ví dụ như 0.6 không thể, no inferior 0.9 TPA tức là 0.6 không ngang bằng.
It might be clearer in German.
Yes, thank you very much to clear this term, because a lot of Vietnamese confused about no inferior. That means equivalent. It's not right. Yeah, that's not right.
Can I make a comment about the approval? You know, it's produced by Amgen in the United States and Boehringer in the rest of the world. Boehringer took the decision to not ask for approval for stroke. Yeah. They say we need it for countries where coronary angioplasty is not available, and we save lives for people with myocardial infarction, and we still have an alternative, which is alteplase. So at least in Europe, they will not go for approval.
Oh, one more question, Greg?
I'm sorry, just take the opportunity to have the expert's opinion and everything. I just wonder whether then we should keep them both, alteplase and Tenecteplase, and just reserve the Tenecteplase, large vessel occlusion. The pathway of management is clearly very different now, and there is pretty good evidence, as you've shown, on the reperfusion and everything. And because of the supply issue, we've got to rationalise it. So maybe you are looking at two strategies for acute stroke.
Thanks, Craig. It's quite possible. But I think the other elephant in the room is that there's Tenecteplase coming from other countries, very close to Vietnam, which will be cheaper than either the Boehringer or the Genentech Roche. And I don't know who was at the TRACE talk in WSO, but there's been one large phase 3 study completed of Chinese Tenecteplase just recently that will be published soon, that shows non-inferiority again. And the Chinese Tenecteplase looks to be quite similar to BI Tenecteplase in terms of fibrinolytic efficacy. So, I mean, BI might well have shot themselves in the foot. They might lose the whole thrombolytic market, the Chinese TNK, for stroke, because they've not acted as they should have, in my opinion.
Okay, thank you. The time's up now. When we have a coffee break. Hẹn gặp lại các đồng nghiệp sau 20 phút. Chúng ta sẽ bước vào cái phiên này. Chúng tôi không có bất kỳ những cái báo cáo nghiên cứu nào cả. Chúng ta chỉ dựa trên sự thảo luận, và chắc chắn là chúng tôi cần đến sự tương tác của quý đồng nghiệp để cho cái phiên này được thành công. Như ta biết rằng đối với hiện nay kháng đông có rất nhiều lợi ích trong việc phòng ngừa, đặc biệt trên các bệnh nhân rung nhĩ. Tuy nhiên cái vấn đề lựa chọn kháng đông nào, thời điểm nào luôn là những cái câu hỏi mà chúng ta đặt ra, và những cái chứng cứ mà chúng ta có được cho đến nay đôi khi nó không thỏa mãn được cho tất cả. Thì như vậy lúc đó chúng ta sẽ cần đến cái sự đồng thuận của ý kiến chuyên gia. Ý kiến chuyên gia là một cái ý kiến chung không thể so được với những cái chứng cứ class 1, thậm chí class 2. Tuy nhiên khi chúng ta không có những gì tốt hơn thì cái ý kiến chuyên gia lại là một cái yếu tố khá là quan trọng. Tôi xin được bắt đầu bằng một cái trường hợp bệnh nhân của tôi. Một trường hợp này thì tôi nghĩ rằng các đồng nghiệp cũng rất là hay gặp. Đây là một cái ca mà chúng tôi chỉ gặp cách đây khoảng trong vòng vài tuần gần đây, cách đây khoảng 3 tuần. Một bệnh nhân nam đột quỵ cấp, nhập viện vì liệt nửa người bên trái vào giờ thứ 2. Và cái expect trên CT scan là expect 9 điểm, và trên cái CTA là đã có tắc cái động mạch não giữa đoạn M1. Bệnh nhân này được chúng tôi bắt đầu sử dụng TPA đường tĩnh mạch với liều 0.9 mg/kg. Bệnh viện tuyến đầu đã sử dụng cái TPA và sau đó chuyển cho chúng tôi. Tức là đây là theo cái mô hình Prep and Ship mà chúng ta vẫn nghe ngày hôm qua. Đây là cái CT scan và cái hình ảnh tái thông sau khi chúng tôi làm cái Thrombectomy, lấy huyết khối, hình ảnh tái thông TC3. Bệnh nhân này sau khi chụp CT scan ngày thứ 2, bệnh nhân này chúng ta thấy rằng có một cái chuyển dạng xuất huyết ở cái bán cầu bên phải. Mặc dù vậy, về mặt lâm sàng, bệnh nhân này lại có tiến triển rất tốt. Sức cơ nửa người bên trái phục hồi từ 3 đến 4/5 và bệnh nhân tỉnh táo hoàn toàn. Chúng tôi chờ bệnh nhân nghỉ nằm ở tại bệnh viện trong vòng khoảng vài ngày sau. Đến ngày thứ 6 thì chúng tôi chuyển viện cho cái bệnh viện trả lại tuyến trước. Và khi chúng tôi chụp lại CT scan thì chúng ta thấy rằng so với cái hình đầu tiên thì cái hình này ngày thứ 6 cái máu nó có hấp thu lại một phần, chuyển dạng xuất huyết có hấp thu một phần. Anh chị thấy rằng theo phân độ mức độ thì tôi nghĩ rằng cái mức độ xuất huyết này là mức độ HI2, nó chưa thành một cái hematoma, nhưng mà nó có chuyển dạng xuất huyết. Như vậy câu hỏi đặt ra cho các anh chị ở đây, chúng ta sẽ sử dụng kháng đông tại thời điểm nào? Và ngày thứ mai là ngày thứ 7, chúng ta chờ 2 tuần sau, chúng ta chờ 4 tuần sau, hoặc chúng ta chỉ xài aspirin. Các đồng nghiệp ở đây mình có hệ thống voting không nhỉ? Đây, các đồng nghiệp xin mời các đồng nghiệp voting. Như vậy là 50% các anh chị chờ 2 tuần, khoảng gần 40% chúng ta chờ, 30% chúng ta chờ càng ngày càng tuột 3 tuần, và khuynh hướng xài ngay ngày thứ 7 khá là cao, tăng lên là 13%, 4 tuần 27%, chủ yếu là 2 tuần 56%. Ca này đúng ngày hôm sau, tức là ngày thứ 7, cho các anh chị đã quyết định xài. Bệnh nhân bị một cái nhồi não tái phát ở bán cầu bên trái, tắc hoàn toàn động mạch cảnh trong, động mạch não giữa bên trái. Các anh chị nhớ lần trước bệnh nhân bị bán cầu bên phải phải không ạ? Một cái bán cầu, xin lỗi cho slide. Bệnh nhân bị tắc hoàn toàn động mạch cảnh trong, não giữa bên phải, nhồi máu não, diện rộng bán cầu bên trái. Các anh chị thấy rằng nhìn cái hình MRI này, đây là một cái bức tranh điển hình của một khối nhồi máu não do rung nhĩ. Một hình ảnh nhồi máu não 2 bán cầu diện rộng vùng vỏ và có cả 2 mặt, một bên là xuất huyết và một bên là nhồi máu. Đó là câu chuyện 2 mặt nằm hết trong cùng một cái ca này. Chúng ta chưa xài gì cả. Như vậy câu hỏi tiếp theo dành cho báo cáo viên đầu tiên của tôi, đó là hồi nãy ông xin slide nó chạy, ông Diener đó, ông nói là cái Diener law nó đáng tin cậy hơn các cái guideline, bởi vì guideline từ 2 đến 14 ngày thì chúng ta không biết ngày nào. Xin cho slide chạy. Như vậy, Professor Diener, can I believe you?
Always. I think the bottom line, the good news from our registry was the absolute rate of recurrent ischemic stroke was really low. It was only 3% until discharge from hospital, which is really good. And the rate of intracerebral hemorrhage was only 1.2%, which is also very good. I still would go with the majority of the attendees here. I would wait for 2 weeks. Unfortunately, in this particular case, it was not a good idea because the patient had a recurrent stroke. And my question to you is, did you echo to rule out an intracardiac thrombus? Did you perform echo to
yes.
exclude an intracardiac thrombus?
Yes, we did.
There was no
but
thrombus.
no thrombus in the left ventricle.
Dr. Diener, I tell my residents that the NOAC's bleeding risk is equivalent to aspirin. I think there was a trial, I've forgotten the name of it, which was aspirin and the NOAC had comparable risk. That's different efficacy, but just in terms of if you make a decision to go aspirin, why don't you make the decision to go apixaban or another one because comparable bleeding risk?
Yeah, remember in the Averroes trial, we excluded everyone who had an ischemic stroke in the last 4 weeks. So all the evidence we have for the similar bleeding risk is beyond the phase of an acute ischemic stroke. This was true for all the NOAC trials. And this is why we performed our 10,000 patient registry to get information on the basically from day 0 onwards to see what happened.
Cái ca này thì tôi lúc mà cái cô bác sĩ đó cô gọi điện thoại cho tôi là khi nào xài thì tôi nói rằng ít nhất là 2 tuần, và đến ngày thứ 7 thì bệnh nhân đã có accident và cổ gọi điện thoại lại, cổ complain tôi rất là nhiều bởi vì ban giám đốc kiểm điểm cổ bởi vì nói xài trễ quá thành ra là bệnh nhân bị đột quỵ.
Yeah, I agree with Professor Diener, but unfortunately, if we see a lot of cases, then they all occur around day 6, day 7. All these cases with AF and or maybe even unknown cardioembolic source with a recurrent stroke, and then we always we did all the things. Patient had good outcome after the EVT, and then they have second stroke and so on. So I'm just wondering if the patient is actually improving despite the large PH1 or PH2 on the CT scan. And sometimes, the Diener rule is either 6 days or 12 days, but 6 days, instead of having a full anticoagulation, I know aspirin is no use. We started these patients on the second day with aspirin. Whether half dose NOAC is maybe useful for these cases who, despite having a big stroke, that you will start on 12 days, but they are improving. If we start them on the 6th day on a half dose of NOAC, whether it's a compromise and would be helpful?
Yeah, number one, in our registry, there was no peak at a particular day of a recurrent ischemic stroke. It was basically linearly increasing over time, over 14 days. In addition, even if you anticoagulate, you cannot prevent all strokes. You reduce the risk of stroke, but there is still a considerable risk of stroke despite anticoagulation. So no one knows whether you would have started a day before. And we see reduced dose. I don't think it would really work because either you have the adequate dose and you can prevent it, or you use a low dose and then it's no longer really effective. Remember, we learned this from the subgroup analysis of the trials, where from the registries, where people got an inadequate low dose because the physician was afraid of bleeding, and this was clearly associated with the increased risk of ischemic stroke.
Actually, I agree with Bernard. Some cases just mild to moderate, and I consider if the patient have high risk, I can start the middle of dose of NOACs. For example, we usually use a rivaroxaban 10 milligram, and then we follow up, and then we repeat the CT scan after 1 week, 2 weeks, and everything is done okay. We can go to 15 milligram. That's the way we do.
Can I make a comment? Going back to Professor Diener's comment about the echo for cardiac thrombus, I think that's a really good point. If you'd done imaging that had shown left atrial thrombus, that would have swayed you towards early anticoagulation. And without advertising too much, if you look at the last edition of Neurology, there's a very good editorial in there from a couple of people recommending that you should do acute cardiac CT immediately following your hyperacute stroke with CT brain and CTA protocol. The Dutch have done a large study in patients with suspected LVO. They do a non-con CT perfusion, CTA arch to vertex, and they do a quick gated cardiac CT. They found left atrial thrombus acutely in 12 or 13% of all patients. And on transthoracic echo, the rate was much, much lower. It was done delayed. Of course, sometimes the thrombus might be gone by the time you get to echo. In our hospital, it takes several days to get an echo. So I think that a lot of centres will move towards a hyperacute cardiac CT as part of their admission CT protocol. Probably take a while at PA, Craig, but most other centres will move along quickly.
I couldn't agree more. And with the modern CT machines, it's just 3 minutes more. Yeah. And you get the aortic arch in addition, which is also, I think, worthwhile.
I have a question for you. There's another rule, that's 1, 2, 3, 4 rule for NOACs in Japan. Do you have any comment about it?
No, I cannot comment on rules from Japan. I can only comment my own ones.
Okay, thank you. And about this case, there's a hemorrhagic transformation already, so it's not your original rule, but it's a last case that with hemorrhagic transformation, so you have to wait for 3 to 28 days. But what factor that decide the point of time of restarting the anticoagulation in this hemorrhagic patient?
If I see the CT scan at day 6, where most of the blood is already absorbed, the patient is stable, I think I would have been comfortable to start anticoagulation between day 10 and 14 and not wait for 4 weeks or so.
Chúng ta thấy rằng một cái ý kiến chuyên gia nó luôn luôn có sự tranh cãi, bởi vì không có đồng thuận, chúng ta không có chứng kiến, nó tùy thuộc vào rất nhiều chuyên gia. Đây là những chuyên gia hàng đầu và chúng ta thấy rằng vẫn có sự bất đồng thuận trong cái việc quyết định giờ nào. Điều đó có nghĩa rằng khi các bạn có những ca như vậy, đừng gọi điện thoại hỏi tôi, hãy tự quyết định của các anh chị dựa trên bệnh nhân, yếu tố bệnh nhân có chuyển dạng suýt hay chưa, nguy cơ bệnh nhân tái phát như thế nào, bệnh nhân có huyết khối trong buồng tim hay không, và lúc đó chúng ta sẽ quyết định thời điểm nào tốt nhất cho bệnh nhân, và chúng ta sẽ học trên những bệnh nhân của mình khi chúng ta theo dõi. Và cho dù chúng ta bắt đầu có xài hay không xài, làm ơn theo dõi bệnh nhân một cách chặt chẽ. Nếu chúng ta không xài, chúng ta phải theo dõi bệnh nhân bị tái phát, lúc nào chúng ta có thể cứu bệnh nhân sớm nhất có thể. Ngược lại, khi chúng ta đã xài rồi, chúng ta thận trọng. Giống như giáo sư Bernard cũng như tôi, thường những cái ca mà nguy cơ cao, chúng tôi thường đắn đo trong việc duy trì một cái liều thấp bằng nửa cái liều bình thường. Ví dụ như rivaroxaban người ta khuyến cáo 15-20 thì tôi xài 10 thôi, để cho nó ăn thử trước vài ngày cho nó êm không, nó êm mình tiếp tục mình làm, đúng không ạ? We go to the next case. Đây là một cái bệnh nhân 84 tuổi bệnh nhân này nhập viện bởi vì một cái đột quỵ rất là nhẹ. Và cái CT scan của bệnh nhân này hoàn toàn gần như là không có gì bất thường. Bệnh nhân này cũng có tiền căn trước đây là bị đột quỵ cách đây 1 năm rồi. Trên một cái tiền căn là rất nhiều yếu tố nguy cơ, rung nhĩ, suy thận, và cái độ lọc cầu thận đo được nó dao động từ 30 đến 40 ml mỗi phút, và bệnh nhân này chắc chắn là có rung nhĩ. Như vậy câu hỏi đặt ra, xin quý đồng nghiệp chọn lựa cái kháng đông nào để chúng ta sử dụng cho bệnh nhân này. Thời điểm thì chúng ta biết câu trả lời quá đơn giản rồi. Những bệnh nhân nhẹ thế này chúng ta nên bắt đầu sớm, đúng không ạ? Nhưng mà chúng ta bắt đầu cái thuốc gì? Vitamin K, rivaroxaban, apixaban, endospazban hoặc là dabigatran. Các anh chị nên nhớ rằng đây là một bệnh nhân lớn tuổi, có suy thận, có tiểu đường kèm theo. Xin mời quý đồng nghiệp voting. Tôi rất là mừng bởi vì chúng ta ở đây chỉ chọn 2% là kháng vitamin K thôi. Chúng ta biết rằng kháng vitamin K không phải là lựa chọn ưu tiên của tôi nếu như bệnh nhân có điều kiện. Và bệnh nhân này cái điều mà chúng ta quan tâm đó là tiểu đường. Xem coi kháng đông trên các bệnh nhân kháng đông mới, cái trên các bệnh nhân rung nhĩ và tiểu đường thì sao, nó có lợi ích hay không, hoặc là trên các bệnh nhân suy thận. Ở đây chắc đồng nghiệp đã chọn chủ yếu là cái apixaban hoặc là rivaroxaban, và cái dabigatran có lẽ nhiều đồng nghiệp lo ngại đến cái chức năng thận, chỉ có 5% thôi. Bây giờ chúng tôi sẽ xin ý kiến chuyên gia. Dr. Chan, which one you choose?
Okay, we have 4 choices. Vitamin K antagonist warfarin is difficult in elderly. The INR fluctuates and they need the monitoring and drug and food interaction, so it's off for me. Secondly, the bigger trend also, because of its renal dependence, is also not preferred even for the low dose for elderly, so it's off. I don't have edoxaban. I think edoxaban actually may be a choice, but it also has higher renal dependence. So I don't have experience, so I cannot comment on edoxaban. So that leaves apixaban and rivaroxaban. Apixaban is a good choice but you have to select according to the criteria for the normal dose or the low dose, 2.5 milligrams. I think she might satisfy the either 2 or 3 criteria. She already satisfies the age over 80 criteria. The creatinine clearance of 30 to 40 may be around serum creatinine of 133. So she might satisfy this. If she has a body weight of less than 60, she also satisfies. So I think if apixaban 2.5 is one choice, then rivaroxaban is actually interesting because for the creatinine clearance, she's already in the 15 milligram. But regarding the Asian patients, we worry that yesterday, the presentation of Professor Diener, we worry about the bleeding risk of rivaroxaban. And actually from a lot of study, including the Danish national study, it actually shows that rivaroxaban 20 milligrams, even for the Caucasians, it might have high bleeding risk. Whereas for the rivaroxaban 15, the protection is actually enough, but the bleeding risk is actually reduced, even for Caucasians. And for Asia, it's different because the Japanese, the high dose is 15 and the low dose is 10. And for Taiwan, they actually recognize both the Japanese and the other countries' recommendations. So they can use either 15 or 10 or 20 and 15. And even for the low dose from Taiwan and Japan, the low dose, even 10 milligrams, the safety profile is reasonable and the efficacy is acceptable. So in this sort of fragile elderly patients, maybe I even go for 10 for rivaroxaban, but I don't know what is the Vietnamese national guideline. If the Vietnamese national guideline is 15, then you go for 15. Then when you rate the 15 and the 20 rivaroxaban, the dose reduction is 25%. But when you weight apixaban, then the dose reduction for the low dose is actually 50%. So then you have to wait whether this patient is high risk of bleeding. If it's high risk of bleeding, I can take the apixaban. If you think the elderly is actually very feisty, and rivaroxaban 15 is actually okay. So we have these diabetes. Okay, it doesn't really change. So Pyroxaban 15, if you feel that the patient doesn't have a really high risk of bleeding, but if you worry about the risk of bleeding, then apixaban 2.5.
But if you choose apixaban, the apixaban is you choose 5 milligram 2 times or?
It depends. I think she satisfied the 2.5. She already have the age, and the renal impairment is already around that creatinine of 133 millimoles per liter. And then you have the body weight.
I think it's Vietnam, Singapore, Hong Kong.
If she's,
we share the same story. The doctor usually prefer the low dose NOACs or even is for TPA. So for this case, I think it's 15 should be okay because it's 10 is a little bit low.
Yeah, 10 may be out of guideline for Vietnam. I don't know what's your national recommendation.
But I see the paper. The 15 rivaroxaban is very good. Very good.
It's okay. The efficacy is okay, and the bleeding risk is actually reduced. And she's already indicated for 15 because you know when you have a creatinine clearance of 30 to 50, it's already 15 for rivaroxaban.
Okay. How about you, Sean?
Yeah, my preference would be the low dose of apixaban, but I would give another important message to this patient is in the next 6 months, 1 year, if you have an infection and you have high fever and you vomit, for example, you have COVID for a few days, come back and see me and we have to take the creatinine clearance and check whether you are still in the 30 to 40 because she might have dropped down to 15 or even less in the context of an acute infection with fluid loss. Then you would have to pause for a few days and then you can start again.
Yes, I think that in the patient, the thing that we consider is that the renal impairment and a very old patient. And so I agree that we can choose the NOAC that not secrete much through the kidney. So apixaban and rivaroxaban is okay. In my opinion, I also concerned about the progression of the renal failure impairment in this patient. So maybe rivaroxaban they have a little bit better profile in comparing to vitamin K anti-vitamin K in protecting the renal. So I prefer rivaroxaban low dose because of ACE and because of renal impairment too. So low dose is 50 milligram is I think the best choice.
Professor, how long we need to recheck about creatinine?
Well, she is a high-risk person because also of the diabetes, and if she doesn't have an infection, I would check the renal function every 3 months.
Okay.
By the way, there is one additional argument for a NOAC and not vitamin K. Vitamin K antagonists have a negative impact on kidney function long-term because you get calcifications in the kidney, and the NOACs have a protective effect on kidney function long-term. This is a post-hoc analysis of registries. So that would be another argument against vitamin K antagonists.
Okay, thank you, sir. Đây là tất cả các cái tổng hợp của chứng cứ khi chúng ta chọn lựa một cái kháng đông hay là vitamin K. Chúng ta thấy rằng tất cả, cho dù chúng ta chọn lựa bất kỳ một cái kháng đông nào ở trên một cái bệnh nhân rung nhĩ, lựa chọn NOAC luôn luôn được xem là tốt hơn, bởi vì việc làm ít nhất là ngang bằng hiệu quả phòng ngừa, trong khi đó làm giảm rõ rệt các biến cố xuất huyết, đặc biệt là xuất huyết nội sọ. Thì trên những đây là cái guideline của ESO, chúng ta thấy rằng đây là cái guideline họ recommend cái NOAC over vitamin K với cái bộ chứng cứ high và very strong. Do đó chúng ta nên cân nhắc cái NOAC cho các bệnh nhân rung nhĩ nếu như bệnh nhân có thể đủ điều kiện. Còn ngược lại, nếu như bệnh nhân không điều kiện, chắc chắn là chúng ta phải xài cái vitamin K cũng đều tốt cho bệnh nhân. Tuy nhiên, quý đồng nghiệp nếu quyết định xài vitamin K, xin theo dõi chặt chẽ cái ANE Đừng cho bệnh nhân một cái toa thuốc 3 tháng mới quay lại, thì tôi nghĩ rằng sẽ rất là nguy hiểm. Please, Professor Greg.
I just asked a question on a related topic, not specifically to this, but I have had several patients on a NOAC who still have cardioembolic stroke, or they've got atrial fibrillation. And it's in the middle of the day, so it's not in the trough, which would be, you'd think, towards the end of the day. They're highly intelligent, motivated, and adherent to their medication. So I know we accept that it's not a perfect treatment, but I just wonder what the clinical decision-making is over. We just accept that it's an imperfect treatment. Do we change the dose? Do we change to an alternative? Do we add anything? Anyway, I think it's emerging as an issue. It does get the patient a bit worried. So what's the decision-making or advice in the context of ongoing emboli on good compliance?
Yeah, about the topic of compliance, I remember a number of cases where I asked the male patients, did you take your pills every day? And he would do this, and his wife standing next to him would do this. So you really have sometimes to check the coagulation parameters to see whether the patient was compliant or not. Usually, I don't see why you should switch, except I think the only reason is to check the dose, whether the patient perhaps got an inadequate low dose, patient doesn't have a high bleeding risk and gets 110 W or 5 apixaban or 15 rivaroxaban, then I would adapt the dose. But otherwise, I can't see a reason. The differences between the NOACs are so small that it doesn't justify to switch.
For the compliance, I want to ask you, for NOACs, when you take drug 1 time only compared with 2 times, which one more compliance for a patient?
Doesn't matter. Both are incompliant, unfortunately, at the time when they have the second stroke. This is, as I said, we checked this in the emergency room, and 70% of the patients had a normal coagulation, so they were simply not compliant.
Professor Diener, just want to ask, there's an emerging, I think they are on clinical trials, there's some results from small studies, and those who have recurrent stroke with NOACs, then they consider, in addition to that, with left atrial appendage closure. Do you think it will be a promising strategy? LAAO closure with NOAC.
Occlusion of the left atrial appendage. I have to be careful because I chair the DSMB of 2 of these trials, so I shouldn't, let's say, comment on this because I'm biased. But you know, we have 3 randomized trials ongoing, and I think we have to wait for the result of the trial.
Okay. This. Okay, Heidi, please.
Just a quick question, a bit of comment. I'll follow up on Craig's comment. I've got a lot of patients who had recurrent stroke on NOAC. Ultimately, I found a lot of them actually got cancer. What's your experience in that? In fact, there's a recent case too. So in your registries and things, do you have any information on that? Because I think if you look hard enough, you often do find cancer in this patient. And what's the mechanism?
Yeah, here I have to admit that in our 10,000 patient registry, we haven't analyzed all the data. We only have now for the main outcome of major hemorrhage, intracerebral hemorrhage, and ischemic stroke, and we have to look at the other things.
Tôi sẽ xin bắt đầu tiếp. Xin nhắc các quý vị đây là những cái khác biệt giữa các cái thuốc NOACs, giữa cái nhóm ức chế 10 và ức chế 2. Các anh chị thấy rằng đối với dabigatran thì chúng ta sẽ rất là thận trọng khi mà cái chức năng thận giảm, đặc biệt là khi chức năng thận dưới 30, đúng không ạ? Còn đối với những cái thuốc 10A như rivaroxaban, dosaban hoặc apixaban thì chúng ta được phép sử dụng cho những cái ca mà suy thận mức độ nhẹ. Tuy nhiên như ông Diener nói đó, chúng ta cần phải kiểm tra cái chức năng thận mỗi 3 tháng. Bởi vì chức năng thận nó sẽ suy giảm, mà nếu như chúng ta để nó suy giảm và chúng ta sẽ có thể gây ra các biến cố, đặc biệt là những cái biến cố về suy huyết não, bởi vì thận nó không thải hết được. Và ông cũng đề nghị là chúng ta sử dụng liều thấp hơn so với cái liều chuẩn mà chúng ta sử dụng. Ví dụ như nếu mà như cái ca của tôi đó thì cái liều rivaroxaban là 15 Nhưng mà nếu suy hơn nữa thì vâng thở ếm hơn, chúng ta xài 10 mg là cái liều khuyến cáo. Còn đối với apixaban là liều 2.5 x 2, tức là nửa liều sau mọi kỳ. Okay, we go to the third one. Đây là một cái bệnh nhân nam 57 tuổi. Bệnh nhân này nhập viện bởi vì một cái đột quỵ nhẹ. Và bệnh nhân này có tiền căn là bệnh lý mạch vành. Và bệnh nhân này đang sử dụng aspirin. Bệnh nhân này cũng có tiền căn về cao huyết áp, về tiểu đường. Và bệnh nhân này hẹp cái động mạch cảnh trong khoảng 50% ở một bên. Thì đây là cái CT scan của bệnh nhân. Đây là cái MRI, xin lỗi. Các anh chị thấy rằng đây là một cái MRI của bệnh nhân. Bệnh nhân này bị nhồi máu ở ngay cái vùng cuốn não bên trái, và một chấm nữa ở ngay cái phần trần của cầu là của cuốn não, đúng không ạ? Và trên đây là cái hình ảnh cổng hương từ mạch máu. Đối với các động mạch nội sọ, chúng ta không thấy được các cái hẹp rõ có ý nghĩa ở các, đặc biệt là các cái mạch máu chính như động mạch thân nền, động mạch cảnh trong, động mạch não giữa hai bên. Và đây là cái hình ảnh chụp MRI. Các anh chị thấy rằng bệnh nhân này có một cái hẹp khoảng 50% động mạch cảnh trong bên phải. Các anh chị biết rằng ở đây là một bệnh nhân này là nhồi máu não và cuốn não, mà cái hẹp này là hẹp 50% động mạch cảnh trong bên phải. Điều đó có nghĩa rằng hẹp này là hẹp không có triệu chứng nha các anh chị. Những trường hợp này khuyến cáo chúng ta điều trị nội khoa thay vì đặt stent. Vấn đề đặt ra ở đây là khi chúng tôi chụp tiếp một cái toàn bộ cung mạch chủ, các anh chị có thể thấy rằng cái toàn bộ cung mạch chủ của bệnh nhân này có rất là nhiều các cái mảng xơ vữa ở xung quanh cái cung mạch chủ. Như vậy đây là một cái bệnh nhân đột quỵ mà cái rất nhiều yếu tố nguyên nhân, rất nhiều yếu tố nguy cơ. Bệnh lý tổn thương trên giường của mạch máu tim, tổn thương trên giường của mạch máu não là chắc chắn, cả cung là mạch chủ, tức là tổn thương rất nhiều nơi về các biến chứng xơ vữa, mặc dù những cái xơ vữa này chưa đạt được có ý nghĩa như là chúng ta chẩn đoán là một cái bệnh lý động mạch lớn. Ta biết rằng động mạch lớn nó phải hẹp trên 50%, mà ca này có một chỗ trên 50% nhưng mà lại không giải thích được cái nhồi máu. Nó không là thủ phạm gây ra nhồi máu ở cuốn não, do đó nó vẫn được xem là không xác định nguyên nhân, hoặc là nó không đủ giải thích cho bệnh nhân này. Như vậy vấn đề đặt ra trên các bệnh nhân này, các anh chị sẽ lựa chọn giải pháp nào cho bệnh nhân? Aspirin, bệnh nhân này đang sử dụng aspirin rồi, hoặc là các anh chị thêm vào clopidogrel. Ở đây tôi xin nhắc là cái clopidogrel không phải giải pháp lâu dài nha các anh chị. Dù trên bệnh nhân nhồi não chúng ta sử dụng clopidogrel tối đa là 3 tháng. Xin nhớ điều đó. Còn đây là lựa chọn lâu dài nha. Chứ còn lựa chọn 3 tháng thì mình không tính rồi. 3 tháng thì ok. Nhưng mà lâu dài thì các vị thận trọng. Thứ ba đó là aspirin cộng với lại rivaroxaban. Và nếu như các anh chị liều low dose từ liều baby dose, tức là 2.5 x 2. Và cái lựa chọn thứ ba đó là clopidogrel. Nếu như chúng ta prefer cái clopidogrel, nghĩ rằng cái aspirin nó không đủ hiệu quả và chúng ta chọn lựa clopidogrel. Xin mời các anh chị vote. Có 15% các anh chị chọn lựa aspirin. Tôi hết sức là phân vân. Một bệnh nhân đang sử dụng aspirin bị đột quỵ và bác sĩ kê lại aspirin. Chúng ta chán một ông chồng quá, đuổi ổng đi, mai dắt ổng về. 15% các anh chị quá rộng lượng.
I think we're treating for the minor stroke. So any minor stroke, you can still give aspirin and clopidogrel for 3 weeks, followed by, if you fail aspirin, maybe you can do some antiplatelet tests, but you can actually follow with clopidogrel. I know there's enthusiasm for the COMPASS trial with this aspirin and rivaroxaban baby dose. But for that trial, it's basically coronary artery disease patients. It's a little bit different. Yeah, I know, but this is a past history also. And then the stroke is actually a secondary outcome. I think some of my colleagues will use that. I haven't been persuaded yet. I don't know What's the other's opinion?
Yes, number one, the cardiac stenosis is asymptomatic and doesn't need intervention. I think it's very clear. No stenting, no surgery. Interestingly, what happened in my country after COMPASS, according to the study, this patient would fulfill the criteria from the COMPASS file because the patient has coronary heart disease, has aortic arch flux, and had a stroke. And then we looked at the prescription data in my country, and it turned out that very few GPs, internists would use a combination of rivaroxaban low dose and aspirin. And why? They were afraid of the bleeding. So there is a benefit, it's very clear, but there's also an increased bleeding risk. And our experience is that GPs and internists are more afraid of bleeding than they're afraid of a recurrent stroke. And it's easy to understand if you are a GP and you prescribe a preventive treatment and the patient has a recurrent stroke, this is the work of God or Allah or Buddha or whoever. But if the patient bleeds, you are blamed. The family will come and say, you prescribed this dangerous drug and my grandfather had a serious bleed. And this explains the behavior, because the behavior is detached from science evidence.
Would you prescribe the COMPASS treatment for this patient?
I don't prescribe anymore. I'm retired.
Yeah, because
I think the question is correct. I still see the benefit is higher than the bleeding risk.
Yeah, I think it's reasonable. I just don't have enough experience. But for a lot of countries, including in Singapore, the problem is rivaroxaban for AF is funded and subsidized. But if you want to prescribe the rivaroxaban 2.5 milligram, it might end up even more expensive than you prescribe your rivaroxaban 5-BD 3 times or something like that. So that also creates another problem.
So first, I want to talk about COMPASS. The COMPASS trial. We see that 40 patient is very compatible with the design and the criteria of COMPASS, and we see that according to the COMPASS we can use it. But I want to ask you about that. What about the guideline in your country? I mean, it is acceptable by the government or by the insurance or not? It's reimbursement for the use of it.
Yeah, again, as I said, the German guidelines were revised, I think 6 months ago, and there is a recommendation for this combination for the patients who fit into the COMPASS inclusion criteria. But again, clinical practice deviates from the guidelines in this respect.
And another issue I want to raise in this patient is that when I see the MRI of this patient, we can see that apart from the two lesion in the brainstem, there is also one small lesion on the left side of the left hemisphere. So for this, we can see that the mechanism may be embolism from the below, for example, from the aortic arch or somewhere else, and it's raised also suspicions about the cancer-related. So should we usually do the scanning for screening for the cancer for this patient or not? So please give your opinion, please.
I'd like to propose another explanation for the lack of uptake of the combination. Is just because COMPASS was done through a predominantly cardiology network, and it doesn't have the same degree of engagement through a neurology network. I think it's overlooked. I think it's a very positive result, but it hasn't been translated into the prescribing area rather than cardiologists. The problem with bleeding is, certainly my experience with the elderly in the context of anticoagulation, is that in our culture, in the Western culture, they're not so worrying about, dying or worrying about, having a major bleed in which they could die. They are worried about having a middle cerebral artery stroke and being aphasic and disabled in a nursing home in a feed. So I think the way in which you interpret benefits of prevention and bleed and risk and everything do a lot depend on the culture, context in which you're having that discussion.
I couldn't agree more. And the perspective of the patient often is different from the perspective of the physician. And this is why it's so important to ask the patient, number one, what do you expect and what are you afraid of? And then you make, I think, a qualified decision what is best for the patient. Don't ask the family because they say, it's fine if the grandfather dies, we can inherit something.
And the other thing is about this patient and similar patients with polyarteries, plaques, and polyartery disease. The other target is actually we should actually lower the LDL cholesterol to the most recent ESC guideline of below 1.4. So I think this should also be beneficial.
Tại sao tôi nhắc đến cái IV-rTPA? Bởi vì trong cái IV-rTPA trên những cái ca mà bị trên nhiều giường mạch máu, khi chúng ta phối hợp aspirin hoặc với liều Prehospital, liều baby làm giảm được đến 44% cái nguy cơ đột quỵ trên các bệnh nhân có bệnh lý mạch vành và 46% trên các bệnh nhân mà có PAD, tức là bệnh nhân bệnh ngoại biên. Và trên các bệnh nhân đột quỵ cấp, các anh chị thấy rằng cái tỷ lệ riêng những bệnh nhân đã tiền năng đột quỵ nó làm giảm được khoảng 44, trên những bệnh nhân đột quỵ nó làm giảm rõ rệt các biến cố trên các cái bệnh nhân đã từng bị đột quỵ. Và các anh chị thấy rằng cái number to treat của những cái việc phòng ngừa đột quỵ khi chúng ta phối hợp aspirin cộng với cái liều Prehospital 2.5x2 nó lên là 37 và chúng ta phòng 1. Cho biết rằng aspirin 100 người chúng ta mới phòng được 1. Thì với cái giải pháp aspirin cộng với cái Prehospital liều baby 37 trường hợp chúng ta phòng được 1. Đây là một cái lợi ích rất là lớn. Tuy nhiên tất cả các chuyên gia đều thấy rằng cái việc mà chúng ta sử dụng có một cái concern đó là gì? Các biến cố xuất huyết. Tuy nhiên các anh chị thấy rằng trong các cái biến cố xuất huyết này đó thì không khác biệt rõ rệt ở cả hai nhóm. Tuy nhiên cái điều giá cả cũng là một cái điều mà chúng ta cũng cần đắn đo. Cái đó là thì công ty bây giờ chắc phải hỗ trợ thêm. Chứ nếu mà xài 2 viên 2.5 mà mất đến 50-70 ngàn thì nó cũng là một cái khía cạnh rất là gánh nặng cũng khá lớn về tài chính cho bệnh nhân. Như vậy đó là 3 cái ca của chúng tôi muốn đề cập các quý vị ngày hôm nay. Tuy nhiên bây giờ tôi sẽ mời các anh chị có 1 hoặc 2 câu hỏi để thảo luận thêm về các lĩnh vực kháng đông thì các anh chị có thắc mắc gì không?
Professor Diener, I'm Dr. Phiên from Ho Chi Minh City University Medical Center. I have a question for you on my clinical patient. When I have a patient have a ischemic stroke associated with AF, and we use DOAC for the patient, and thus he have recurrent stroke. When he admit to our hospital, we reassures about the anticoagulation. He obeys very strictly. The dose, the anticoagulation that we use at that time, that's rivaroxaban. The dose 20 microgram a day. At that time, so I wonder whether I switch or not. But finally, when have consensus with cardiologists, we still keep rivaroxaban. But he had recurrent stroke for the 3rd time. Yeah, Professor.
But as I said, you always have a relative risk reduction, but you cannot prevent 100% of strokes, and it's the same for recurrent stroke. And as I said, the differences between the 4 NOACs are so small that usually I would not switch from one to another one.
Professor, my question is that whether we should, when the patient use anticoagulation strictly, regularly, when have recurrent stroke, should we perform the searching for the thrombus in the atrial by the further techniques, for example, TEEs or CTs of the heart, for example, because my patient at the 3rd time we although on the cardiac thoracic echography, we haven't found any thrombus in heart, but because I'm doubtful about the thrombus, so I performed the TEE for the patient, and we discover the thrombus at the left atrial.
If you identify a thrombus, then the treatment is IV heparin until the thrombus has resolved, and then you start again with the NOAC. I think we have no randomized trials, but the only benefit we have for ischemic stroke in association with the thrombus in the atrium is on IV heparin. Again, no randomized trial, but at least observational studies. And we have no evidence that NOACs are effective in intracardiac thrombus.
Professor, but it's a very special case when we consensus for the third time with the cardiologist, we switch to the anti-vitamin case because of the high risk for recurrent stroke, and we also have used Lovenox for breathing while waiting for anti-vitamin K reach the range we expect, but the patient also have the fourth time recurrent stroke. And my question is that when the patient have many times recurrent stroke while using DOACs, should we switch to anti-vitamin K, and should we use for the breathing as well? Professor.
I think this gets too complicated. I'm sorry. You know, I don't think we should go into so much detail in a particular patient.
Chúng ta sẽ có một câu hỏi cuối cùng từ online. So we have a last question as we receive from online participant. So the question is about the using of anticoagulation for the patient with end-stage renal failure, especially the patient under hemodialysis. So should we use and what kind of anticoagulant should we use for this patient?
You are aware that there are small trials in people on dialysis with different kinds of anticoagulation. The clear bottom line is it's a nightmare. Whatever you do, these patients have a very high risk of mortality, an extremely high risk of bleeding, and it's basically almost the same whether you do nothing, then they die. If you anticoagulate them, they bleed. So I think in some cases where they have dialysis, but the overall survival prognosis is good, then you should consider LAA occlusion in this patient. That's one option. How are you?
I think giving vitamin K, giving warfarin is difficult, but if it can be achieved, if you can maintain an INR, many renal physicians actually switch to warfarin if they are not LAA occlusion candidate. The other thing is in the FDA is actually both IV-rTPA and apixaban are actually approved down to end-stage renal failure on dialysis. Whether you should, they actually still use the same criteria, 15 milligrams, or apixaban is using the 2 out of the 3 criteria for the 2.5 milligrams PD. But whether it's still a little bit too high, sometimes I really frail patients, 90-year-old, end-stage renal failure, I actually just give them maybe 10 milligrams of IV-rTPA or 2.5 once a day of apixaban a day, and they seems to be doing okay, but they are really anecdotal. But you can actually give, because there's actually an FDA label on it that you can give, so with the risk.
Okay, thank you. Thank you, both of you. And we move to the next section, the final session. Chúng ta sẽ đến cái phiên cuối cùng cho buổi hội thảo ngày hôm nay, năm nay. Đầu tiên tôi xin được mời Professor David Liebeskind sẽ trình bày về cái vai trò hệ thống học trong cái can thiệp nội mạch trên các bệnh nhân nhồi não cấp.
Thank you very much. It's a pleasure to speak to you again about precision medicine, but in this case, in acute ischemic stroke, and what we're doing specifically around the mainstay of endovascular thrombectomy. So I like to believe that we are entering a new era, relatively new era of disruptive innovation in the field of acute stroke. In acute ischemic stroke, endovascular thrombectomy in the United States and a lot of places is becoming the mainstream, the mainstay of therapy. But precision medicine has relevance here conceptually because the concept or the idea is that there's not a perfect treatment for all patients because each patient is slightly different. Every stroke patient may present somewhat differently with different imaging patterns at different time points with different baseline demographics and comorbidities as well. So we have to pair the specific therapeutic intervention with the baseline patient pathophysiology. And we've struggled with this over the last many years, actually, in figuring out whether the core size at baseline, the size of the infarct, whether it's time, whether there's other functions, facets of or aspects of collateral flow or collateral status, and how these two things come together to perfect the right outcome. Now, just taking a giant step back, some may say, well, you know, why are we interested in an outcome? We have endovascular thrombectomy, even where it's applied, you know, so it's ideal. There should be no problem in terms of outcomes. It is true, as I've mentioned many times recently, that about 50%, half of all patients that have endovascular thrombectomy have no difference in the infarct size, no ischemic evolution between baseline and 24 hours later. So that's as close to a cure as we're going to get. But the big problem is that there's a difference between successful reperfusion angiographically with endovascular thrombectomy and how patients do clinically at day 90. And there's still many different approaches that are being tried to try and narrow that gap. And a lot of this, I think, will be based on the baseline imaging or characteristics of specific patients. So where the field is going is towards the next set of questions. This is what we largely call indication expansion, or the expansion of indications for thrombectomy. The large core is the number one item that is in progress of being addressed. I do think that within not just years, but within months, we're going to have more and more data about this. So we're going to have data, and I am biased because I know some of the data, and we all know some of the early data, that you can treat large core patients with larger infarcts. The big question is, how large, measured with what technique, with CT or MRI, how low can you go on aspects? What's the difference between an aspect score and a core size on rapid, for instance? So there are remaining questions, but in general, large core will be amenable to treatment overall. I'll be shocked if the remaining trials go in the other direction. Distal occlusions, everybody and their cousin has their latest trial of a distal occlusion. So there are many different trials now. There's about 7 or 8 that are being run. Some are based around specific device therapies, specific approaches, and others are based around slightly different aspects, taking all comers with all patients with all different types of therapeutic interventions. There, it's a much more difficult question because we do not have good data on the imaging evolution, the clinical outcomes of distal thrombectomy compared to controls. The control data is very, very limited. It has not been properly registered. The next big question that is exploding day by day is the question about adjunctive medications, EVT plus. And when I say plus, this is sort of a reversal of what we've been doing or how endovascular thrombectomy came about, because we've had IV thrombolysis, whether with Tenecteplase and alteplase, for a while in different settings. And it's not just the thrombolytic approach, but other antithrombotic approaches, collateral enhancement, neuroprotective, cytoprotective, glioprotective approaches, and even device approaches to improve downstream perfusion or perfusion in the downstream territories. So there are also device approaches to this. The other situation is the situation with intracranial atherosclerotic disease. We touched upon this a little bit yesterday in terms of rescue stenting, but it's not the same. The collateral flow patterns, the imaging patterns at baseline are different than in a complete occlusion due to a cardioembolic event. So I like to think this way in terms of general schemes, in terms of the big picture, is that you have a proximal occlusion. And I've said this for many years, occlusions are not, the treatment the best treatment for occlusion is, for ischemic stroke is removal of the blockage. But the blockage is not what causes ischemia. The ischemia is caused by a lack of blood flow or sufficient blood flow via the collaterals. So the intervening question is how much collateral flow does that patient have when they have that M1 occlusion or proximal occlusion? And in terms of gradations, there's no surprise in terms of where your core is and where your penumbral region is, because it's all a question of the tributaries or the distribution of your collateral flow. A lot of debate as to where your core is and the penumbra has to do with the topography of the collaterals. And of course, this has to do with when you measure it as well. And if you measure too early, you may get one pattern. And if you measure at a later time point, you may get a different pattern, because stroke and hemodynamics are dynamic. They change minute to minute and hour by hour. So we speak about theranostics, which is the combination of diagnostics and therapeutics that I mentioned yesterday. It's what's, ideally, conceptually, providing the perfect treatment for that one individual patient. Now, there's a problem, because we'll never get to this answer from large randomized controlled trials. We always do these large randomized controlled trials and then try and assume that everything is perfectly balanced. And we know very well that that's not the case, that there are always imbalances. And then the question comes up, well, perhaps we should do subgroup analyses. And everybody says, no, wait a second. We're not powered for that. We shouldn't be doing that. Now, unless you want to do another prospective study to look at that specific subgroup with a different sample size and a different design, you really shouldn't be digging into the data that way. But the problem is we take the data and then we use it as dogma to use at the bedside in terms of what we do to treat from that point forward. And we were discussing this yesterday and over the last couple of days. The field changes and the data changes every 6 months, every year. It constantly changes. So you can't just chase every trial and then decide that that's the perfect treatment until the next trial comes along. That doesn't make much sense. But we do know that patients are different when they present. These are two patients with right MCA strokes, exactly the same time of onset to imaging. Two very different stories, and both due to the same mechanism. The treatment here should be different. The target of our therapy should be different here, I believe, at least. So the way that this has interestingly evolved is that IV thrombolysis in general was sort of a miraculous treatment. Many of us may have forgotten about this, but IA thrombolysis and endovascular approaches actually existed before IV thrombolysis. It was being trialed in the 1980s and early 1990s at the time when then IV thrombolysis was graduated into routine clinical practice with the IV-rTPA trials. But the TPA and thrombolytics were based on not having any data or a specific imaging focus. You didn't have to see anything. Seeing nothing, having a bland CT was great. That's all you needed. You didn't even have to know that the patient was actually having a stroke, because if, God bless, if they're having a stroke mimic, well, you can use the TPA anyway, and it's probably not going to make the patient bleed. So very, very easy. And what happened over the years is there was less of a need or restrictive focus for finding something on the imaging. Endovascular therapy is almost the opposite. What we learned from synthesis in 2013 was that you needed a target to treat. You can't just give a lytic downstream and assume that you're going to improve perfusion without seeing a clot. And you need a proximal arterial occlusion at first, in very selective trials that came out in 2015. But now when we're looking at other situations, these are not the perfect situations. Large core, distal occlusions, these are different scenarios where we have to tailor what we're doing. And we're still waiting, as I've mentioned, for some of these trials to complete in the near future. At the same time, the selection of treatments for the neuroprotective and cytoprotective and protective studies has been what I like to say turned on its head, done completely incorrectly. The first trials of neuroprotection, I remember being involved in a tremendous number of neuroprotective trials where there was absolutely no likelihood that neuroprotective agent was going to do anything in such a stroke patient with large infarcts 25 years ago. But we still did the trials, and then the trials failed, and then we asked, why did the trials fail? And we kicked ourselves. We started to do it again in the setting of endovascular thrombectomy. Escape tried to predict who would benefit from the no-no drug, neranotide, based on selecting patients who are likely to do well anyway. If a patient is likely to do well with endovascular thrombectomy, then they don't need neuroprotection. That's the backwards approach. That's not who you should be selecting. You should be selecting patients that clearly need your drug, forgetting about whether they got the thrombectomy, putting that aside because the thrombectomy is established. So the trial design has got to be modified now. And I think we're going to see a tremendous number of trials. I've seen 8 different trials come online and start in the last 6 months from different parts of the world where everybody is ready to try every single type of drug available in combination with thrombectomy. It's not that these won't work. I actually think that they will work. But the magic is not going to be in the individual drug. The magic is going to be in the trial design. So taking a giant step back and thinking about all the variables that affect how we select patients and who's going to do well or not with specific therapies is based on rethinking our trial design. So this is a bit disruptive in terms of innovation. And the reason I say that is because it's not something incredibly new. You know, it's not radically new. It's disruptive in terms of trying to do something slightly differently with the tools that we currently have available. And I think that this is something that we will see in the next coming years. So a lot of this has to do, of course, with collateral flow. And collateral flow is important, but, you know, as I say at home when I'm in service all the time, is it should never be used as an excuse to not treat a patient, you know, because the patient has good collaterals or to definitively make decisions one way or another. It should be taken together in consideration in terms of their collateral status. It's one consideration. It is important in terms of how patients do and their evolution over time, but it doesn't provide an answer as to the main therapy as to whether you should or should not treat those patients. There's a difference in terms of outcomes, and we saw this in Hermes in the reanalyzed patient-level imaging analyses of the landmark trials many years ago. Collateral status very nicely predicts in now what is old data outcomes at day 90. There's no question about that. And collaterals determine how that patient does even before you get to the angio suite. So if you have perfect collateral status, as we see in Moya Moya and other situations, you can completely occlude your MCA, your proximal arteries, and have absolutely no symptoms. It's well compensated for. In the setting of acute ischemic stroke, it's not perfect. So patients fail, their collaterals fail, and somewhat slowly over time. There are other factors that occur pathophysiologically as to what drives the progressive collateral failure. And collaterals are different, for instance, in diabetic patients than in non-diabetic patients. But that course is different for individual patients based on collaterals. Unfortunately, we don't have a perfect predictor of collaterals at present. Once you reperfuse as well, the tissue fate, or what happens in the downstream tissue, has a lot to do with their baseline collaterals. When you have poor collaterals and you reperfuse a region, the tissue response is not as robust. So patients can be categorized in terms of their course based on collateral status in general. And collateral status has a lot to do with some of these individual variables as well. So it's not, you know, a truly independent variable, so to speak. But I do believe that collateral status is a way, as an example, of implementing precision medicine. Patients with large core infarcts and the fast progressors have poor collaterals rather than those with robust collaterals. So imaging tells us a lot about how we may be able to treat patients differently. We can do a lot of imaging, and you can do this now around the world, most of it with multimodal CT, a small amount with multimodal MRI nowadays. But we see a lot of information. Multimodal CT is CT with contrast, is the way I like to say. And not to get too much into the technical details of this, but, you know, this is how we ordered other radiologic studies many years ago, with and without contrast, and MRI, with and without contrast. With multimodal CT, this changed 25 years ago, 20 years ago, and it subsequently evolved. We got into a lot of debate about single-phase CTA, multi-phase CTA versus CT perfusion. They all use contrast, but they film the brain in different sequence. All right, so there's a different way of imaging as you're watching the contrast go through the brain. So to speak about it in these terms, It's what you would call a dynamic CT. You're watching the temporal information of the contrast flow through the brain. So you can do it in a static mode. So you can inject contrast, wait a while, and take one image. And then you can do what's called triphasic or multi-phase, or others have joked about calling oligophasic CT, not multi-phase CT when you do 3 phases. That's been around since the late 1990s. And then again, published in the early 2000s, actually both times by Taiwanese groups. Then we have CT perfusion, which in essence is a multi-phase CTA. And there's been a lot of debate about this as to, do multi-phase CTA, don't do CT perfusion. And it's quite frankly, it is extremely confusing because it's intentionally confusing because there is no difference. You have to look at the, as people like to say, you need to look at the label, the package label, and see what you're buying. All right. So if you're getting a CT with contrast, where you're getting 40 and 60 second acquisitions as the contrast is flowing through, or even 10, in my books, that's called a CT perfusion study. That's not called a multi-phase CTA. But some groups have heatedly argued about that's multi-phase CTA and not CTP. Going in reverse, how much spatial information do you really need if you do a CTP about the distal vessels? There's no relevance about the size of the vessels. You can generate a CTA from CTP. You can work in the other direction as well. So a CT with contrast is important. It shows you a lot more than you'll get with a non-contrast CT. It's done so quickly now, at least in the United States, within 2 minutes, that people don't even know that they've had it done. It's extremely fast. You don't even have the time to argue about whether you should get a multi-phase CTA or a CTP. You just basically do it. So single-phase CTA is a static image. It gives you a relatively anatomical image at a later time point. And of course, it depends on when you're imaging and which phase you're in. But it does have temporal information embedded in it. And you can do a lot of fun things with the contrast intensity and look at the flow via certain collaterals based on single-phase CTA. So I don't think that CTA single phase is outdated, so to speak. You can use it when you have it available. And in general, with imaging, that's what we should be doing, is using whatever we have available and not wish for something else. You can do multi-phase CTA and flat panel detector CTA in the angio suite. So in some places around the world, we're starting to go in this direction. We take patients directly to the angio suite. It's not the most practical approach because you'll wind up with a whole bunch of patients in your angio suite, and depending on how busy you are. But the imaging is beautiful nowadays. Philips and other groups have refined flat panel CT to provide, quite frankly, better images, CT images, than you can get on a lot of routine CT scanners. So you can see a tremendous amount with the patient on the angio table. Again, going back to this difference in terms of CTA versus CTP, what we see is downstream flow via collaterals when you have a complete occlusion. Greg Albers and others like to say that this equals collaterals. This does not equal collaterals. It's a measure of collateral perfusion. It's one way of looking at it. And the hypointensity, the hypoperfusion intensity ratio, or the HIR that's called, is simply a ratio of the different Tmax values. And it tells you a little bit about the topography or the spatial features of the perfusion. The best way to see the spatial features of the perfusion is to look at the image. All right, an exact measure of an HIR is not going to be perfect. It's an abstraction. It's one score or measure. So looking at the imaging is really important. And the more people use automated pipelines for imaging, the more they'll tell you that the most important thing is not the automated result, but looking at the images and in a user-friendly format. So there's been a lot of debate about this, about large core aspects versus perfusion. The simplest way of describing this in terms of how big that core is they're not the same technique. They're doing different things or looking at things differently. Aspects on an MRI is different than on a CT. And aspects is not the same thing as a core defined by CT perfusion. The problem is that CT perfusion core also varies in how true it is in terms of predicting an outcome of the tissue, depending on whether it's at 1 hour or 6 hours or 14 hours. So it becomes very, very difficult. So you have to, again, many groups have shown this now, You have to know the time from onset to the imaging to be able to interpret the imaging. Now, that was a problem because imaging for a number of years was being promoted to remove the time factor. This is not as much of a problem if we don't use imaging as an absolute about whether we should treat or not treat. As long as there's an indication that there's a mismatch of some type, it's reasonable to go forward and treat. I wouldn't be so hung up on the exact measures of the mismatch in terms of the cc's or the milliliters of brain tissue that's left to be saved. So aspects in CTP measure different things. Aspects do not fluctuate. CTP, because it's a hemodynamic variable, does fluctuate. So it can change. You can re-image that same patient 2 minutes later, and if you did a repeat perfusion study, your core may be a different size. So part of it has to do with the timing and a guess based on that. So there have been many groups that are now published on whether you need CT perfusion based on the time. Before that, we looked at Stratus. Before those other publications came out in the last couple of years, we looked a number of years ago at Stratus. And lo and behold, the same thing occurs as to whether, in terms of the outcome of patients, as to what, in terms of whether you need the CTP based on timing. Early on, it doesn't really make much of a difference. If you use CTP in a later time window, you can use it as a tool to help refine things. So some have looked at this and said, well, therefore, you don't need it early. And some that say that actually still acquire it early. So, you know, how do we deal with that? Well, we get the imaging and we interpret it as we will. And that's a fair assessment. So where perfusion is going to be changing is, and especially in terms of this debate about which technique you're using, is in what's been called MEVO. This is like when you buy clothing of a different size. You know, I guess the logical sequence is you go from large to medium to small. Nobody wants to touch small vessel as a label because small vessel disease to stroke for providers means something very different. So MEVO or distal occlusions is the terminology that's been used, but it's all about the distal perfusion. So the question that's come up is, how do you best diagnose a distal occlusion? And bluntly, I'll tell you, the people that say, oh, we can see it on a CTA, that's complete trash. All right. It's trash because most people will tell you that they're still missing and they need automated techniques to tell you whether an M1 occlusion is present or not, or an M2 occlusion. Try that in a distal M2, an M3, an M4, an A1, a P1, a P2, forget it. All right. And the other thing is it doesn't really matter following the course of that vessel and seeing the vessel and the size of that occlusion. That's not relevant. The best way to see a distal occlusion is with perfusion. The interesting evolution here is that nobody cares necessarily about the Tmax value and the perfusion results, the automated results. Yesterday, I told you about how Tmax, was basically validated with rapid based on cardioembolic occlusion, and it was never trialed and never demonstrated in stenosis or ICAD or extracranial stenosis or acute stroke with underlying ICAD. Same thing is true in distal occlusions. Be careful. You cannot simply apply the Tmax thresholds and the other perfusion values in distal occlusions just because we've been told they work in proximal occlusion. We need to look at the data properly. A Tmax 6-second delay in a distal occlusion does not have the same meaning or doesn't exist in the same degree with distal occlusions as compared to proximal. So with multimodal MRI, we see brain tissue and we've been doing this since the mid-90s in combination with endovascular therapy. So literally for the last 27 years, I've been involved at UCLA in terms of using multimodal MRI with perfusion with all the same sequences we're using now in combination with endovascular therapy. So not much has changed actually with the use of MRI. What's changed is its availability. So the few places that do MRI acutely are UCLA, one or two other centers in the United States, France, and Japan, and that's about it. It can be done, but it's a question of whether you have it available. So a lot of the questions nowadays no longer have to do with selecting the perfect patient. If you have the imaging available, if you have thrombectomy available, the answer is going to be go. The answer is going to be you go if you have a proximal occlusion. The decision-making that's much more difficult is what happens in the angio suite. So some of you may not see this, but we now see this in a lot of recent trials where everything is based on the number of passes. So we have some information that, and people will tell you that, getting a first pass effect is ideal. You can't dictate that or order that. I can't ask any interventionalist, please, whatever you do, guarantee me that you're going to use one pass of any device and get me a full perfect reperfusion in 2 minutes. There's no such thing. It doesn't happen. As I like to tell Sam Zaidat and other colleagues, when you get a first pass, not effect, but a first pass result, you got lucky. And that's about it. And if it happens on the second pass, is that much worse? Not really. If you have underlying athro, if you have a complicated course with multiple passes, yeah, it becomes more complicated. But there's a lot of decision making that takes place in the angio suite about how far to go, how many passes you should do, and whether you should go on or not. And there are really no rules for this in terms of what's perfect reperfusion. So perfect reperfusion is ideally stopping all ischemic injury because of the proximal occlusion, as well as dealing with downstream effects. And a lot of those downstream effects we know are deleterious or harmful. They occur hours later in the ensuing hours in terms of how the tissue evolves. And it's not just, the safety aspect of hemorrhagic transformation. Hemorrhagic transformation is one manifestation, but no reflow or incomplete reperfusion in the microcirculatory bed is a real problem. And that's actually the target of a lot of these novel therapies that are being developed. So people are talking about, collateral protection, enhancement, neuroprotection, cytoprotection, and all kinds of protection. It remains to be seen and proven as to whether you can do this. But the only way to prove it is with proper trial design. So there's a lot of things that can be done. And I mentioned this earlier, but there are now magnetic devices with nanoparticle injection to actually draw endogenous lytic without giving an additional drug or adjunctive drug in the downstream microcirculation. Because what happens is that the lytic otherwise goes through the flow routes that are available and not into the microcirculatory plugging and the static or stasis in the microcirculation downstream. There are different targets that are important in terms of these entities here: reperfusion, injury, edema, inflammation, and a lot that can be done in the hours after or right after treatment. Hypothermia is being revived now post-thrombectomy. We're going to be seeing trials of this with selective cooling as well. So there's a lot that's going on that can narrow this gap between endovascular thrombectomy and getting those perfect outcomes. So I'm going to end with a couple of pointers in terms of what we've learned in general. What we've learned from the imaging, and as an imaging core lab, I've learned a tremendous amount about seeing tens of thousands of cases of thrombectomy done with periprocedural imaging over time. I've lost count. It's probably on the order of about 30,000 cases or so. But basically, a couple of lessons that we've seen is that aspects, at least this is my bias, aspects works. Aspects decay is very uncommon. When you see a subtle feature, subtle abnormality in certain regions early, that counts. And it really doesn't change very much in the first few hours. Half of all patients with endovascular thrombectomy, 50%, now 7 years ago, in data that was available 7 years ago, 50% of those patients have no increase in aspects at 24 hours. That's pretty remarkable. But there are other lessons that we've learned. The aspects growth is not necessarily due to just ischemic evolution. There's pressure differentials, there's edema, you knock out neighboring regions. So there are a number of things that occur. The other thing is that we have to remove our obsession that has existed for a number of years in the imaging world of final infarct volume. There is no such thing. All right, CT versus MRI will give you different results at different times. All right, what we do see on a practical basis is that the aspect score on a CT at 24 to 72 hours, and not to be exact, but in that range, is a pretty good surrogate actually for final infarct volume. And from a practical standpoint, in my eyes, that's good enough. There's no such thing as perfect. In terms of occlusions, what we've learned is something very interesting about atherosclerotic versus cardiobolic occlusions. The same way that I mentioned that in intracranial athero, you have flow abnormalities that occur because of in plaque that develops because of flow abnormalities in proximal regions of the vessels, like in the posterior circulation, in the basilar, as well as in the proximal M1. The opposite happens with embolic occlusions. Early on, emboli do not stop in the main stem of an arterial segment. They go because there's no difference in the caliber size of a straight segment of an artery changes by about 1%. So from 100% maybe at most to 99%. An embolus that's a spherical object that flows through the bloodstream is not going to lodge in the main stem of a vessel. It lodges at the next bifurcation. So those emboli go, most MCA strokes occur at the M1, M2 junction. Now, if you wait long enough, and depending on the time, what we've seen is that you have stasis or and lack of good flow proximal to that. And then you have clot that develops and becomes more difficult to treat over time. So it's not the same thing as when, depending on the time. So much like with a perfusion, you may get a different result at different times. Your CTA and the nature of the occlusion changes based on timing as well. There's some other features that can be looked at in terms of clot porosity and permeability from perfusion studies and some things that can be done, but these are still not in the mainstream. Finally, perfusion, of course, is important. Perfusion is the most important thing when you think about acute ischemic stroke. As mentioned, the perfusion thresholds that we use were idealized based on cardioembolic occlusion of the MCA specifically. Tmax 6 does not equal penumbra in other situations. It does not equal that when you have an underlying stenosis. Before that, in other vascular territories, when you have bilateral lesions, when everything else is slightly different, or in distal occlusions, as mentioned. E-TICI in terms of reperfusion is not a new scale. It's a consideration of the degree of reperfusion across the whole spectrum from 0 to 100%. We have recently developed what's called the cross-sectional TICI, which at a necessity we have to do in Swift Direct because when you give an adjunctive drug, you want to be able to measure the change of reperfusion from the baseline imaging before you gave the IV lytic or drug to the time that you gave to the angio suite and how you compare those two. And you're not, obviously they're done at different time points and what the cross-sectional imaging approach to TICI is, it's a way of assessing whether your lytic did anything prior to thrombectomy. And that's going to be very important in terms of ongoing and emerging thrombolytic trials. So novel frontiers that remain to be attacked or addressed. Pre-hospital side that you heard about earlier as well, direct to angio. You'll hear about a lot more in coming years. Adjunctive therapies, you're going to hear a tremendous amount about. And there's a lot of interest now in terms of what else you can do in terms of stimulation and recovery early. We talked about ICAD and the role of rescue and plan stenting yesterday as well. So coming back to this slide that I showed you earlier, there's a lot more to come. And it's a very exciting time in the field, but a time of, again, what I would refer to as disruptive innovation. That it may be incremental based on tools and drugs and devices that we already have available, and not necessarily something dropping from the heavens. So anyway, it's been a pleasure to be here. These types of discussions we'll have at the Collaterals meeting. Tang and many other colleagues from Vietnam and around the world will join us next week when I'll be back in Los Angeles. We're looking forward to this. Next year, we're going to be holding the Thrombolysis, the TTST meeting in combination with Collaterals in Los Angeles again after the World Stroke Congress. Thank you very much.
Thank you very much for the very interesting presentation, and we will discuss later. So we move on to the next speaker. Please come to the stage with Professor Mark Parson to talk about the pre-hospital stroke care, current and future, please.
Okay. Hi, everybody. Good segue, David, into pre-hospital stroke care. And David's picture of the core and the penumbra was much prettier than mine, so I'll skip over this. but pretty much the same thing, the little black clot, which doesn't look like a real clot, but as you know, when you block the middle cerebral, you get the core, and you've got collateral flow that preserves particularly the cortex, but sometimes the deep tissue as well. There's some interesting papers on collateral flow between the lenticular striate vessels as well coming out, which is quite interesting. That's the aim of the game, is to salvage tissue in the penumbra before it becomes incorporated into the core, however you measure it. And you know, for years we've worked on trying to get an efficient code stroke process. So we talk about the door to needle time, the door to CT, the CT to needle, and Professor Anderson's hospital just won a big award at the WSO for fast door to needle time, didn't they, Craig? The Angels Platinum Award. Sorry? Diamond. Is that better than platinum? I'm not sure. I'd have to ask my wife. Anyway, it was the top award, wasn't it, Craig? Yeah. So obviously you can get your door to needle time down efficiently if you've got a team. Unfortunately, often the problem that occurs is that in the daytime we've got all of this team. In the nighttime we might have one junior doctor doing the code stroke on their own. And many of you would be familiar with this artist and his pictures of the emergency room. This is really what the emergency room looks like in many countries, including in Australia. And so it's actually quite chaotic. And many of us thought a long time ago, actually going back a step even further, Craig will remember we practiced medicine. When I was a medical student, there wasn't anything called an emergency department. Basically, we had accident emergency and patients with medical problems were triaged to the medical team and patients with surgical problems were triaged to the surgical team. And many of us think that that was a more efficient process than what happens now. But I'll stop there because I get in trouble when I criticise emergency medicine. But we realised a long time ago that the gains to be made in hospital in terms of faster treatment are limited. And there's a lot more that you can gain pre-hospital than you will gain within hospital. And funnily enough, we were actually looking at this way back in the early 2000s. When I was up in Newcastle, which is north of Sydney, we had one comprehensive stroke centre before endovascular clot retrieval, just giving lysis. We had multiple other smaller hospitals where the patients were often distributed to, and by the time they got to us, it was too late for thrombolysis. So we went to our local ambulance service and said, how about you guys identify stroke in the field and notify us and come directly to John Hunter Hospital for thrombolysis. And our thrombolysis rates increased dramatically after that pretty simple initiative. And in fact, we won an award from the New South Wales Premier, Maurice Yema. I look a bit younger there. That's because that was 2007. And then that PASS protocol was adapted across New South Wales. And of course, you know, the UCLA group were doing similar stuff earlier than that with you know, I think it was called LAPS, wasn't it, David? It's pre-hospital scores. So it was very clear a long time ago that the pre-hospital scene is really somewhere where we can make huge gains. And now I guess with changes in technology, the capability to put imaging devices in the back of ambulances, we're really working a lot more intensively in this pre-hospital scene. And we really want to, obviously people talk about the golden hour, which they stole from trauma. If you do the right things in the first 60 minutes after severe trauma, you usually save the patient's life, and that's pretty much the same for stroke. Indeed, if Princess Di had been treated appropriately for her multi-trauma, she'd probably still be alive now, of my emergency colleagues tell me. Anyway, so in Australia, as you know, some of us live in the big cities near the coast. But a lot of our population live in tiny little places in outback Australia, and they're a long way away from expert stroke care or any other care for that matter. So we have a big disparity in terms of rural versus metro outcomes. And in fact, we even have a pretty big, and this is quite similar, I think, to the US, we've actually got a pretty big disparity between people in a metro and outer metro parts of the city in terms of their outcomes. So we were lucky enough to receive funding from the Australian government a few years back to develop the Australian Stroke Alliance, which is lots of partners, academic partners, industry partners, health services, ambulance services. And we've got quite a few goals, but the crux of the matter is to look at particularly at new pre-hospital portable brain imaging, to look at whether we can change the models of care for pre-hospital stroke assessment, particularly with ambulance. And because a lot of our regional rural patients live way out in the outback, we're also looking at whether we can put small portable imaging devices into air ambulances. We have a thing called the Royal Flying Doctor Service, which flies out to patients all over the place, and we're hoping to get devices into the back of some of their planes. The groups that we're working with currently include what I call microwave imaging, which the companies don't like me to call it that. They call it electromagnetic imaging, but it's basically looking at electrical changes in the brain. There's nano scanners, which are like a different type of CT scanner that use a different tube and are much more lightweight. The image resolution still needs to be worked on, in my opinion. And then there's the bigger but still more mobile CTs, which are produced by Samsung, which used to be, which was subsumed. Sorry, Neurologica made the Ceratom scanner, which was used in the first stroke ambulances. Then Samsung bought them, and they've got a new version out now. Siemens have got a new mobile CT as well. There are some other devices we're working with that I'll mention later. So the traditional pathway, as you well know, ambulance dispatched, on scene, transport, ED arrival, EDCT, TPA. And you can see that there's actually quite significant time between ambulance dispatch and ED arrival. And one of the ways that you can address that is obviously to have what's called a mobile stroke unit. And that's me in the back of the Melbourne one, and I look really sick because there's no windows. And when you drive for about an hour, you get really motion sick. And in fact, some of my colleagues take ondansetron before they do a shift on the mobile stroke unit. It's because often what happens is you get called to one job, the local crew gets there first, and they stand you down. So then you go to another job, and you might be on the road for 2 hours without a break. So it can be quite nauseating. But anyway, that's just a side thing. But the Melbourne Mobile Stroke Unit was the first in Australia, set up in 2018. It's been pretty successful, generally liaising about 80 to 100 patients a year on board. I'll just show you some of the other data. I'll flick through some of this. The Melbourne model is the more traditional model with 2 paramedics who are pretty highly trained. And I'm not sure about in your country, but paramedics in Australia now have a university degree. They still have a neurologist on board, but they're about to start a trial looking at remote neurologists, and of course that's done quite commonly on other MSUs around the world. There's an expert stroke nurse, and there's a radiographer that we call Rambo because the chief's Fran, otherwise known as Frambo. That went too far forward. So basically, the time difference that's been shown on the Melbourne model and other MSUs around the world, including Germany and the US, is that you can save alarm, what we call alarm to needle, of about 45 minutes on average, based on the difference between the traditional pathway, ambulance dispatch, ED, treatment with TPA versus treatment on scene after you do a CT on the mobile stroke unit. Interestingly enough, in Melbourne, there was an even greater difference in terms of time, reduced time to thrombectomy, because in Melbourne there are 2 24/7 comprehensive stroke centres that offer endovascular therapy. There are another couple of more boutique centres that offer endovascular therapy as well, but the 2 main ones are Royal Melbourne and Henry Mars Hospital at Monash Medical Centre, so they're quite spread apart. The mobile stroke unit in Melbourne has a CTA capability, so if a large vessel occlusion was identified on scene, they generally get thrombolysis on the scene and then be taken directly to the nearest comprehensive stroke centre, and that led to quite dramatic reductions in alarm to puncture, groin puncture. And just to show you in comparison to the top Grotterbar, except this is time epochs rather than MRS. You can see that at Royal Melbourne Hospital, treatment in the golden hour for the traditional pathway is 3%, almost non-existent. On the MSU, up to about 14%. But you can see even in the first 90 minutes, so that's the grey and the red, that you're treating almost half of the patients on the MSU in 90 minutes, which is where you know the most dramatic treatment benefits are with thrombolysis, as shown by the original NINS trial. Now, those of you who know Aussies well, is we tend to shorten people's names and put IE on the end. So this is Lauren, who's one of our great stroke nurses that I tried to poach to Sydney, but unfortunately her boyfriend's in Melbourne and he wouldn't move. We call her Big Lozzie, and that's my daughter Laura. We call her Little Lozzie. She's a bit older than that now, but the two Lozzies we call them. And David and I have discussed this, and I think we're in agreement, and I think Henry probably is too. The mobile stroke unit is a great advertisement for stroke. It's a great billboard for stroke because you see it all over town with all the, National Stroke Foundation, Boehringer on the side, Royal Melbourne Hospital. It looks fantastic. But do you think it's really going to have an impact at a community level? I mean, the Melbourne Mobile Stroke Unit assesses about 500 patients a year and treats about 100 patients with stroke. If you look at that on a population level, that's not really a very big impact. So I think the real money in pre-hospital is to change the model of care across all ambulance, not just with an MSU. You might have a flagship MSU that you can show off to your friends and politicians and get donors money, but I don't think it's really going to have an impact on a true population level. Part of the Stroke Alliance's work is what we call developing stroke-capable ambulances. So this is just a regular ambulance, and this is laying down the groundwork for future portable imaging that we can stick in all ambulances. And as David alluded to, there are probably at least 20 different devices being in various stages of development that for so-called portable brain imaging. And I'm not talking about CT. So I've already shown you the sort of the pathways and the current workflow. You can see, so up the bottom is the current workflow for thrombectomy and thrombolysis, and then you've got the MSU model, which is always going to be boutique, and then you've got this SCA or stroke capable ambulance model, and you can see currently it's got a SCA, transport, CT, thrombolysis, thrombectomy. The future definitely will be SCA, some sort of brain imaging, thrombolysis on board, and then transfer for thrombectomy if necessary. Pardon the little green thing, I didn't come up with that. That was one of my colleagues that made this slide. But basically, we're that I think that comes from the Hermes collaboration, that graph, if I remember correctly. Anyway, so this program's now about to be kicked off. We're running a couple of SCA projects in New South Wales, so one in the Hunter, one in southwestern Sydney, where the hospital I'm at, Liverpool, is central to, one of the comprehensive stroke centres. And we're going to run 2 catchments in regional Victoria. And for those of you who aren't that familiar with geography of southwestern Sydney, it actually extends quite a long way down the coast and inland. And just for example, Campbelltown is a pretty large primary stroke centre, and literally and figuratively large because there's a very large population of Polynesian people there, and that they have very high rates of stroke. So the problem is though, if a patient with an LVO goes to Campbelltown currently, there's that on average their treatment, their time to thrombectomy is 2 hours later than if they present directly to the comprehensive stroke centre at Liverpool. So the goal is to identify these patients in the field and transport them directly to the comprehensive stroke centre. I won't bore you with the times, but we think with modelling that we can save up to 2 hours on the current model, which be quite dramatic. In regional Victoria, again, the numbers are smaller. So out of Metro Sydney is densely populated. And I might add, apart from having a large Polynesian population, we've also got a very large Vietnamese population in southwestern Sydney, and very good beef noodle soup in my local shopping centre. The Victorian sites are a bit more regional. So Ballarat is in Western Victoria. That's a regional city. So we'll be looking at so currently what happens with stroke in regional Victoria, if they're assessed, they'll go to the closest primary stroke centre, then they'll be treated with thrombolysis and then transferred usually by road or air, depending on distance, to the city, Royal Melbourne or Monash, for thrombectomy. That again can lead to considerable delays, sometimes many hours. So again, the goal is to see whether we can transport patients with LVO in regional centres directly to a comprehensive stroke centre. It would still be ideal to give them thrombolysis in the field, but that'll happen later. So the current stroke capable ambulance project is using a combination of the FAST score, face, arm, speech, and then what we call, rather, I guess, immodestly, the Hunter 8, because we sort of cut down the NIH stroke score to 8 items a few years back and showed that a score of 8 or more was reasonably sensitive and specific for LVO. And we'll be communicating with the paramedics and the in-hospital stroke teams via an app that's been developed by the Stroke Alliance and is already being used on the Melbourne Mobile Stroke Unit and is currently being used for telemedicine in South Australia as well. It's called Zeus because it's on the cloud. Again, I didn't come up with that name. It's a bit lame if you ask me, but anyway. Anyway, so the goal is really to see is paramedics will be able to use this tool to go through the NIH stroke score, and they'll get decision assistance about whether it's likely an LVO or not. And if they're uncertain, they can communicate either via phone, text message, or we can do video conferencing with the paramedic and the patient with this app. I won't bore you with all of the stuff. These are just snaps from the app, but you can go through the NIH stroke score. It directs you through. It gives you communication very similar to WhatsApp, but it's probably more secure. It's certainly there's been plenty of so-called penetration testing. That's for the ambulance officers. That's all just showing you the app. I won't bore you too much with that. But I want to show you some of the assessments that the paramedics are doing in the field now in these trials. In the stroke capable ambulance, you can call. I think that one's got Jeff Donnan on there that you can call. And you can push. So if you see a patient in the field, you can push a notification. I'm seeing a patient NIH score as such, could be an LVO or on a bypass, etc. You can track them, see how far away they are from the hospital. Pretty cool. I won't bore you with that one. That's too long. So this is more for paramedics, but just to show you there's a whole heap of education behind this as well with the paramedics. The problem is that paramedics are fantastic to work with. In fact, without going back to my emergency department dissing, we've found that generally the paramedics are much more accurate when you get them to use the scale than the emergency doctors are in stroke. So they're actually great to work with. We're using this cut down an NIH score, but with some preliminary work, we found that the extinction inattention score on the NIH, traditional NIH score, was the only item out of the 8 which wasn't strongly correlated between the in-hospital neurologist and the paramedics. So paramedics would often miss neglected inattention. So we've actually swapped the standard sort of extinction inattention score or way of scoring it out of the NIH for the TAP test, which was developed by the Henry Zhao and Bruce Campbell. So basically, that's where you use. Typically, it's of the left side's weak, but obviously patients with right-sided weakness and left hemisphere stroke can have neglect as well. So you stand on the weak side. Obviously, you observe if there's any neglect of the side you're looking at. If there isn't, there a 0. But if they're looking away from you, you tap them and say their name. If they look at you, you've overcome the neglect, they get a 1. If they don't, if they still look the other way, then they get a 2. I just wanted to talk a bit more about mimics because this is something that we really try and educate paramedics on. And I must say we've had more success in educating paramedics on diagnosing Bell's palsy than we've had on educating peripheral EDs, because on the telestroke roster, most of the false positive calls that we get are about patients with a Bell's palsy or isolated facial weakness. That just seems to be something that people struggle with. But in general, you shouldn't. But hemiplegic migraine is quite relatively uncommon, but certainly quite difficult to diagnose in the field. So this is something that we try and train the paramedics to recognise. But of course, it's much easier if you've got a past history of migraine and you can get, and the patient's not aphasic. I guess we always say, if this is the first time presentation of headache and focal neurological symptoms, then you really should consider that it's a stroke. And then the other one is the classic functional neurological disorder. And a colleague of mine, who Henry knows, Liz Pepper, that's interested in functional neurological disorder, surveyed 200 clinical colleagues, not just neurologists, surgeons, psychiatrists, general practitioners, allied health, and asked them, how often do you see patients with functional neurological disorder in your practice? And 40% of them said rarely, if ever, which means they don't recognise it. So there's actually a lot of education to be done on the medical side about recognising functional neurological disorder. So to expect paramedics to pick it up is quite difficult. But there are a few signs that we talk to the paramedics about. I've given up trying to educate the emergency docs on it. And anyway, so but we say in this case, because we've now got this communication set up with the paramedics, they can actually call us. You can phone a friend or a friendly neurologist. So the other thing that is really critical, I guess, and David alluded to it a bit, is premorbid function. And you heard that outcomes are quite, from thrombectomy and thrombolysis, quite dependent on premorbid function. But I think it's important to remember that the modified Rankin score was developed to measure disability or function after a stroke, not before. So that's the biggest problem with it. And in fact, my premorbid Rankin score is 2, because I can't run 5K in under 20 minutes anymore. So look, I mean, it's a silly score if you ask me, but it's the best we've got at the moment. But the problem is it's a bit like an aspect score, David. It's highly variable between observers. So and particularly if the observer is at a peripheral hospital and wants you to take the patient. So the peripheral ED will ring and say, I've got this 90-year-old, they're completely independent. And then when they get to you and they come for a thrombectomy and they get to you and you find out actually they lost their license 2 years ago because they kept crashing into things. They can't get out. They don't shop. They don't do any of their own banking. They're basically in a granny flat. And the other question that we ask is, can the person be safely left alone for 24 hours? And you find that no, the relatives have to call in every couple of hours to check on them. So we're actually getting the paramedics to do a premorbid Rankin, but then, I had to put this in because this is the new politically correct Rankin score. Can you see why this is politically correct? Because there's a boy and a girl one. We probably should have a gender non-specific one as well, actually, shouldn't we? A C. But anyway, I just had to put that one in there because we're in this era. So in Australia, I don't really know. I think Chris Bladen might have come up with this acronym originally. We call it the DBS score, driving, banking, shopping. And I think a lot of us actually, I use this as a rough cognitive screen in the clinic when I haven't got much time. Are they still driving? Do they do their own banking? Can they do their own shopping? And so we're actually getting we do it in hospital as well, and we're looking at validating it and seeing if it might be used to improve the pre-morbid assessment. I don't think it will replace a Rankin, but we've actually got some early data to suggest if you ask these questions on top of the Rankin, it actually improves the accuracy of the pre-morbid function, particularly in that questionable range where you're thinking, is this a 2 or a 3 of pre-morbid score? So we're getting the paramedics to do that too. But all of this stuff I've talked about is really laying the groundwork for portable pre-hospital brain imaging that will allow us to treat in the field. For those of you who are Star Trek fans, maybe it'll be something like this, but there are lots of other devices. And in fact, if you're a big Star Trek fan, you'd be aware of the tricorder where they wave it over the patient. It gives them a diagnosis immediately. We're actually working with a small company that's developing a handheld MR device that will work a bit like that. So that's probably 2 years away from pre-hospital trials. That's pretty cool. One of the companies we're working with the Stroke Alliance is called EM Vision, who are based in Brisbane, and they've got this microwave helmet which measures sort of electrical function of the brain and generates these maps. They've done a single in-hospital study up in Brisbane where they're based, and they've suggested they can distinguish between ischemia and primary hemorrhage, but I'm somewhat sceptical. So we're about to start an in-hospital validation study of about 400 patients at Liverpool and Royal Melbourne. We'll see how that goes, but that will certainly, if that's accurate enough, that will be tested pre-hospital as well. And so I think definitely in the future, the pathway will really change. I think that we will give thrombolysis in the field, and as David mentioned, collateral enhancement. There'll definitely be scope for giving that pre-hospital, and I think it'll be hopefully something that's done broadly and not just in the bells and whistles, very expensive mobile stroke unit. I might mention it costs, I don't know how much it costs in the US, but to set up a mobile stroke unit, it's roughly about $3 million to kit it out. And then it's about $3 million a year to staff. That's Australian. So it's not cheap. So you would need to save a lot. You'd need to reduce a lot of disability to make it cost effective on a community basis. So I think that's it. Yeah, that's some of the team at Liverpool and some of my broader research team on the next slide from across Sydney and Melbourne. Thanks very much.
Thank you, almost very interesting, especially the SCA program is very realistic. So we come to the last speaker with Professor Greg Anderson with the topic of intensive BP lowering after an endovascular thrombectomy for acute ischemic stroke.
Well, good afternoon. Thanks very much for staying right through to the end. And I feel very privileged actually to present some data here with esteemed company of experts and everything. Be interesting to get their opinion on some of the results here. So it's a broad title, blood pressure lowering, specifically in patients who've had endovascular treatment. And I'll give a bit of background, but I also want to provide the results of a study that's just published and presented at the World Stroke Organisation conference on Friday, the Enchanted 2 MT study. So look, I think we all accept that high blood pressure is bad for the brain. We've seen that very often in various clinical situations of acute hypertension, for example, preeclampsia, eclampsia. And we're all very familiar that low blood pressure is also bad. There's a certain level of diastolic blood pressure where you can't perfuse the coronary arteries. I think it's about 65 millimeters. But in between, what's the optimal blood pressure in the context of the brain? There's been a lot of epidemiological studies, and I'm just presenting one recent study that I came across showing this U-shaped relationship. It's a registry from China. As the blood pressure goes up,
get a bad outcome. If the blood pressure goes down, get a bad outcome. And it's very similar. And they suggest that the best blood pressure should be around 120 or 140, somewhere in the middle there. And this is pretty consistent across all outcomes, whether that be functional outcome, neurological deterioration, hemorrhage. But the other complexity is that the brain is in a very unstable situation in the context of acute ischemic stroke. And you've heard very nicely from Professor Liebeskind around that in terms of collateral blood flow. And the other thing is that we've had this advice to us that the auto-regulation in the brain can shift in patients who have had long-standing chronic hypertension. It shifts up. And therefore, if you lower the blood pressure, there's a higher threshold or lower threshold in which you could get harm. Now, I've been doing blood pressure trials for the last 10 years or so, and in any of the subgroups, I've never shown any heterogeneity, but it's this physiological belief we have that maybe if you've had high blood pressure for a long time, you have to be a little bit more careful. So a lot of controversy, a lot of clinical, biological, physiological, pharmacological, imaging things to make it all seem very, very complicated. And therefore, you get a lot of opinion as to what you should do. We tried to address the question of blood pressure control in thrombolyzed patients in the Enchanted trial, published a few years back. And in fact, we had several centres here in Vietnam take part in the study. And you can see here in the modified Rankin scale amongst the over 2,000 patients who were randomised, overall result was neutral, a little bit disappointing. But one of the arguments was that the blood pressure difference between the randomised groups is very small. Our target was to get the blood pressure below 140 within an hour, seemed pretty reasonable, but that didn't translate into a clinical outcome. What we did see very clearly across any measure of bleeding in the brain, highly significant reduction. And all of these measures of hemorrhage in the brain were done by a central core lab with very careful measurements. And we made sure we went through all of the scans to make sure we didn't miss anything. So we think it's a pretty reliable result. But it raises this question. We could reduce bleeding in the brain, and we know that any type of blood in the brain is bad for you. Why didn't it make a difference in terms of clinical outcome? And I'll come back to that in a minute. The other thing is that in Enchanted, it was finishing at the time that endovascular treatment trials were becoming positive. So Enchanted really was a pre-endovascular trial. We only had about 110 patients that had endovascular treatment. So in that particular subgroup, and a very important clinical group, we don't have a lot of information. Now, we did go back and do a post hoc subgroup analysis in patients that we thought might be the clinical population that would be eligible to endovascular treatment. We used a number of different criteria based on clinical severity. And in this subgroup analysis post hoc, it actually suggested the shift was towards worse outcome for blood pressure control in the larger ischemic group. But you know, with observational data, post hoc data, you can never completely adjust for the various confounders, but it just raises a potential concern that maybe we have to be a bit careful in the larger subgroup. So we have ongoing uncertainty about risk and benefit, and we also have uncertainty about hemorrhage and clinical outcome and why there might be this discrepancy between blood pressure controlling bleeding, and we know that from intracerebral hemorrhage we can tampen out the bleeding. Why can't that work in the clinical, in ischemic stroke? So this year we presented the result of these analyses at the European Stroke Organisation conference, still trying to get the manuscript published. Our reviewers have been a little harsh with us, but we wanted to determine the size of cerebral ischemia amongst the enchanted participants. So we went back and this was all pre-specified, where we looked at all of the scans amongst the participants and we carefully mapped out the size of ischemia to try to determine whether the intensive blood pressure group increased the ischemia. And we pre-specified our analysis, even though we already had indicated that this was part of our original plan in the study. And so this is the flow of the patients, and we pre-specified that our first analysis of the imaging would be on CT scans at the 24-hour. And we adopted this approach because it's more pragmatic, it's more towards clinical decision-making, it's what you do and everybody around the world. But it's a subgroup of 600 patients or so. We also had some patients who had follow-up MRI, and but then we had a lot of patients who had CT scans at different time periods. They might have had it a little bit earlier, they might have had it a bit later and everything. So we have we've done the analyses in a variety of ways. So the first analysis with just on a 24-hour scan, and then we did various analyses on all of the other scans that were available. So it's sort of as a sensitivity. So this is a subgroup of the sample, and there were no difference in the baseline characteristics, but I just wanted to highlight that it is a small difference in the systolic blood pressure between two groups. So if we do a randomized controlled trial, as a trialist, what we try to do is make sure that the patients are different to increase your estimate of the treatment effect. So here are the analyses within an unadjusted, within a simple model with adjustments, and then a more complex adjustment. And you can see here that the size of ischemia is very small that we can pick up on the CT scan. So in the intensive group is the median here, because it's very skewed as well in terms of the distribution of the data. So the median was 0.3 versus 0.9, not significant by any of the adjustments. I also put down the measures of intracerebral hemorrhage and clinical outcome just for completeness here, but it was not significantly different. And here's the sensitivity, which I mentioned before. So for the small number of patients that had the MRI, the volume, the median volume, 2.3 versus 2.9, not significant. Then if you combine CT and MR, no difference. And then any follow-up scan, no difference across all the models. So bottom line was we could not show that intensive blood pressure lowering to less than 140 produced any difference in ischemia in the brain. So the next question is, well, what's the relationship between bleeding in the brain, ischemia, and the outcome? And, before we did that, it was across the subgroups. These were pre-specified subgroups. They're all listed here just because it's a little bit hard to read them in the forest plot. You can see here where the point estimates are, but there's quite wide 95% confidence intervals, because once you get to the subgroups, the number of patients is a bit smaller, but there's no statistical heterogeneity. There's no obvious trends emerging. And this is what I was saying before. We look for this interaction between the various factors. So interaction between infarct and hemorrhage, interaction between blood pressure treatment and infarct size, blood pressure treatment and hemorrhage. And the only significant relationship, interaction, was between infarct size and hemorrhage. So the bigger the infarct, more likely to bleed. But no significant difference between blood pressure treatment and infarct size, again, reassuring. And we couldn't find in this analysis that blood pressure treatment and hemorrhage worked. So the key strength of this data is the randomization because all of the other data is all observational. It's all association. But here we have specifically the ability to look at intensive blood pressure lowering as an intervention on a clinical outcome. And we tried to do things as rigorously as we could, pre-specifying everything, documenting it, publishing it, making sure the measures were as accurate as possible. But it is a clinical trial population, as pragmatic as possible. There's always a criticism there. We didn't pre-specify that the brain images had to be done on a particular approach, or specifically thin slices, so we had to take into account all the different noise of different scanners, different cuts, and also the primary analysis CT, which, as you know, is a pretty poor measure of cerebral ischemia. But it gives us some indication. So from these analysis, the original Enchanter population, broad range of thrombolyzed patients with acute ischemic stroke, we didn't show any adverse effects on ischemia. Very reassuring. What determines hemorrhage is the size of the infarction. So we should take that into account when we're thinking about outcomes from endovascular treatment. So could it be, we haven't clearly answered it, could it be that intensive blood pressure lowering after reperfusion is lowering the risk of hemorrhage in dead tissue, cerebral ischemia infarction, continuing to evolve in infarction, and that's what determines clinical outcome, is the infarct, the ischemia. And we have to look at this in more detail. So this brings us on now to the very important question of endovascular treatment and blood pressure control. And this is, you know, a revolution in medicine in our time. And you've heard the data, and again, Professor Liebeskind has said, well, it's been a great success. We can achieve very high rates of reperfusion, but many patients still make a bad outcome. And what else can we do that's simple to improve their outcome? And one of the things is that we could modify is blood pressure, because a lot of people remain hypertensive after endovascular treatment. We can modify it pretty well, and it looks relatively safe. So does it work? The current guidelines all give it level 2 because there's no direct randomized controlled trials, and they extrapolate from the very conservative 180 systolic margin, which was used in the original NIH thrombolysis trial, because the investigators sat around a room and they decided we can't have it too high and we can't have it too low. Let's choose something in between. And it's stuck with us for the last 20 to 30 years. And as a consequence, there's a lot of different opinions. So this was a very nice survey that Dr. Mistry did amongst various hospitals in the US. And you can see here that there's a divergence of opinion as to what you should do for your blood pressure management according to reperfusion. So I think if there's no reperfusion, most of us are rather conservative. There's still problems of blood flow into the brain. We would be wanting to keep the blood pressure a little bit higher. If there is a good opening of the blood vessel, good reperfusion, there's a move to being more aggressive. Most people are happy around 130, 140, but some people are even very aggressive. They want to go 120. And even some neurointerventionists, and I work with a neurointerventionist, and he's very aggressive. He wants to get the systolic blood pressure down to 110 and keep it at 110 for the next 36 hours. And I've even got some neurointerventionists who want to elevate the blood pressure. They want to bring it up to 180 with pressor agents because he thinks that you've got to perfuse the brain and that will be good. So we don't know. This was a very influential publication from the Mr. Clean study that you know, and I think this has driven the view to be aggressive. In this study, the best outcome was a blood pressure, systolic blood pressure of 110. But it was a blood pressure in the emergency department before endovascular, not during, not after, as the patient presented. But I think some people have said, 110 is probably the best. So this is what they've used. I thought this was a very interesting study. It was a single centre study, Spanish study, cohort study. They followed up their patients, but they prospectively collected very good information on reperfusion and its relationship to blood pressure levels. So some of it was TCD, some of it was CTA. And overall, you can see there's a J-shaped relationship. And the best outcome post-endovascular was about 110. But once it was lower, then there was a bad outcome. So it was a J. But if they divided it by good reperfusion or no reperfusion, you can see the relationship is shallower for no reperfusion, and the J, the inflection of the bad outcome starts to happen a little bit higher, so maybe about 140. But for good reperfusion, didn't seem to be any harm. Just keep the blood pressure down below 120. And that has guided us in the development of the Enchanted-2 trial, which I'll be presenting in a minute. Now, there's been a number of systematic reviews. This was the first one that was published in the journal Hypertension, an aggregate data analysis, and they did just a pooling of the overall results, and then they did some internal adjustments. And you can see that in general, that a reduction in blood pressure overall was beneficial for outcome. And then more recently, it's an updated meta-analysis in neurology published this year where they used an individual patient meta-analysis. And again, they show very nice linear relationships between levels of blood pressure and outcomes. So the lower the level, the better the outcome, even down to below 120. There's only been one randomized controlled trial before Enchanted-2, which was from France, 3 hospitals randomized over 300 patients post-endovascular treatment with good reperfusion of the anterior circulation. Their target was to get blood pressure between 130 and 140 and then above 140 within an hour. Their primary outcome, which was a little unusual, which is sort of a surrogate for reperfusion, was intracerebral hemorrhage. But then they also collected all of the standard outcomes that you're very familiar with over to 90 days. The bottom line was no change in outcome. These are the blood pressure parameters. So according to this protocol, and when they achieved on average mean systolic blood pressure of 128 versus 138. And also the other thing to say here was they adhered to the protocol quite well, not perfect, but quite well. And there were very few low dips in the systolic blood pressure, then less than 100. And that may be relevant to the results of Enchanted-2 that I'll share with you now. So this is how I presented the results on Friday. We started as Enchanted-2, but we built this as a collaboration with Chinese partners, and we merged the two names as Enchanted-2 MT. A lot of funding behind this, both from government and industry, as a true China-Australia collaboration. And I do need to recognise an acknowledgement that there's a very strong China trials research group. In fact, you've had information on the direct MT trial presented at the meeting, and Professor Xiaoming Liu in the centre and Pengfei Yang were the principal investigators for that, and we've joined forces with them. And also Dr. Lily Song is the head of stroke at the George Institute in China. We've been working together for several years. So this was a very strong and productive collaboration with the Shanghai Hospital Research Group. So just to summarise around the results, very consistent epidemiology, higher the blood pressure post-endovascular, the worst outcome. Enchanted shows a signal for hemorrhage, but not clinical outcome. Small blood pressure difference, and not many patients were for endovascular treatment. French blood pressure trial shows it's safe, but no clinical outcome, and wide-ranging opinion, no randomised evidence to set policy. So Enchanted 2MT, multi-centre, it's an international study. We started with funding in China, and the plan was to extend the study into other countries as the funding was secured. We used a very similar open pragmatic design with a probe measurement. It's adults treated according to the guidelines with LVO, acute ischemic stroke of any large vessel, who remained with a systolic blood pressure of 140 for 3 hours after the procedure. And we define that, as you know, by E-Tiki score above 2B and no other contraindications. We use the central randomisation with minimisation to balance out the prognostic factors. And we purposely did this to ensure that we got a definite result. So the intervention group was to less than 120 within an hour. And I've shown you the data that suggests that's plausible and safe. And then the control group was a very liberal guideline, broad range, 140 to 180. Primary outcome was ordinal shift on the modified Rankin scale. We checked for intracranial hemorrhage and serious adverse events, standard secondary outcomes, and we predefined 11 subgroups for analysis. So as an ambitious study, we powered everything on conservative parameters, very plausible, over 2,000 patients to be randomised. We were always doing intention to treat analysis. Our primary analysis with a simple adjustment for the minimisation factors, and then a more expanded adjustment as a sensitivity. And we also did per protocol analysis. So despite COVID, we kicked off the study in Shanghai in the middle of 20, and things were a bit slow to get going, but they were going really well, and recruitment was picking up. And the Data Safety Monitoring Committee had a meeting in February when they had, after about 600 patients were randomised, but they only had 347 primary outcomes. And they alerted us to a safety concern. And this came as a great surprise to us. We had no indication anywhere in the outcomes. We had no investigator report any serious adverse event directly related to the intervention, either formally or informally. No one rang and said, oh, a bit concerned about that patient. It came out of the blue. So the recommendation was to suspend recruitment, which we did, until all of the patients randomised could finish their 90-day outcome so they could have another look at the data, because the Data Safety Monitoring Board had specific stopping rules, which are highly conservative, and but you can still get chance with the early results. So they did all of this and the signal on safety persisted, and recommended that we finish the study and analyse the data, which we've done. So these are the results. We had nearly 2,000 patients screened. These are all from China. We didn't have the opportunity to extend outside of China. So about 821 randomised. It's of which we lost a few patients because they withdrew consent. It should be, it's 407 in the more intensive group. That should be 409 in the less intensive group. And very good follow-up and near complete measures of the primary outcome. So let me outline the baseline characteristics. The first thing is in a randomised controlled trial, got to make sure that the characteristics are balanced, and they are balanced. So there's no real surprises here. Average age was sort of late 60s, normal, more men than women. The presenting blood pressure in the emergency department was almost 160 systolic. Clinical severity, 15, median, that's probably about right. And they presented with a median time from symptom onset around 4 hours. So for David's perspective on the plain CT, there was about a third where there were visible ischemia, and in a subgroup, about a quarter of the randomised patients where they had CT perfusion, you could see that there's quite a large perfusion core mismatch. The clinician reported etiology for the stroke was intracranial atheroma in over 40%, which is not surprising in a predominantly Chinese population. And after the procedure, most people achieved good reperfusion. They randomised pretty quickly from the procedure. So the overall time of onset was about 9 hours from symptoms, and the blood pressure after the procedure was very similar to what it was before procedure. Now, overall then there was about a third had thrombolysis. Interesting, a single pass that came through as a prognostic factor here, single pass. Recanalization is about a half. And the other thing is quite a high use of tirofiban amongst the Chinese participants. So in terms of the blood pressure lowering, there was no difference in the pattern of treatment, it's just more intensive in the intensive group. And that translated into almost a 20 millimetre difference in systolic blood pressure over a full 24 hours. And you can see that there was good maintenance of the blood pressure out for 3 days. So there's no doubt our Chinese investigators followed the protocol pretty well. And so how did that translate? In the common odds ratio, it was highly significant towards worse outcome in the intensive group. And you can see, according to the shift in the categories, no difference in sex mortality, but the levels of disability worsened and less people having no symptoms or minimal symptoms. And this is both in the primary and adjusted analyses. So that's 0.01. The Data Safety Monitoring Committee didn't make the decision on 0.01. This is what they made the decision on. So in the conventional binary 3 to 6, 53% versus 39%, almost a doubling in the odds ratio, 0001. But if you just look at the disability and survivors, that's very clearly highly significant. And we also did an ordinal shift where we combined categories of NIH stroke scale, and that was highly significant, and it was worse for functional component as well as overall on health-related quality of life. No difference in hemorrhage, no difference in length of stay, no difference in serious adverse event, and a post-hoc look at recurrent ischemic stroke, no difference. So this change in NIH stroke scale became apparent at 24 hours. So this is the shift upwards. So the red is the intensive group. There was an early change in neurological deterioration or possibly lack of neurological recovery. And then at 7 days in the function. So that translates into bad clinical outcome. Now, these were our 11 subgroups. You can see here they're all to the right. not significant. No clear differences. There's a bit of a shift down there for incomplete reperfusion, but the statistical measure of heterogeneity was neutral. So, major finding: good reperfusion post LVR acute ischemic stroke, mechanical thrombectomy, the blood pressure 120 systolic target, worse functional outcome, consistent across pre-specified subgroups, and that was also an early apparent effect on neurological function. Nothing on mortality. Presumably this is on the microcirculation. It's insidious ischemia. Now, there's always the issue about generalizability. There's a Chinese population, differences in management, workflow times. We haven't got the brain imaging data at the moment, which is really important, and we're working hard to get that, but we won't have that reported till next year. We've done a quick look at different blood pressure parameters and outcome, and we need to look at that in more detail. You know, was it the speed? Was it the target? Was it the duration? We have looked at the dips, and half of the patients in the intensive group had blood pressures below 100 at some time, but no SAE for a hypotensive event, which is quite interesting. So this is insidious changes that are happening in the brain. It's not something that's alarmist that you can see, like cerebral edema, midline shift, or a hemorrhage. So the clinical implications are we still believe that you've got to control blood pressure, and we're moving beyond 180. I think most of us are pretty comfortable down to 140. We've now defined a lower limit, which we never had before, and particularly in this high-risk group, you can't go below 120. We do need more data to look at the subgroups. That's why we do meta-analysis. And we do need to look at the ischemia and understand what particular subgroups are more at risk than others. Unfortunately, we haven't defined the optimal target. We've found harm, but we've left a window where we still need the direct evidence. So we are picking up, regrouping, start again on a part B with a blood pressure target of 130, which I think is very reasonable. Okay, so I'll just finish, and again, you can't do these sort of trials without a lot of collaboration, goodwill, good effort. There's a lot of people involved in the study, and the publication is now available on the Lancet website. I know it's behind a firewall, but you should have that available, and I think it's a really important clinical trial that's guiding our management. Thank you very much.
Thank you very much for the presentation about the blood pressure lowering in NP. Chúng ta đã kết thúc cái phần bài báo cáo, thì chúng ta sẽ qua một ít thời gian cho một vài các cái câu hỏi mình có thể thảo luận thêm. Thời gian thì cũng đã trễ rồi, nhưng chúng ta sẽ có thêm vài câu hỏi.
Tôi có một cái bài kết quả nghiên cứu của giáo sư Quét, tôi rất là thú vị, bởi vì cho đến nay chúng ta không biết được cái mục tiêu huyết áp, chúng ta có nên kiểm soát huyết áp ở các bệnh nhân mà chúng ta can thiệp hay không. Đó là một cái câu hỏi mà tôi rất là muốn biết, bởi vì chúng ta làm can thiệp này rất nhiều mà chúng ta lại không biết cái mục tiêu tốt nhất cho các bệnh nhân là bao nhiêu. Thông thường thì tôi sẽ phụ thuộc vào cái mức độ tái thông của bệnh nhân. Nếu như bệnh thân tái thông tốt, TC3 hoặc ít nhất là TC2B, thì chắc chắn tôi sẽ hạ áp và mức huyết áp giảm dưới 160. Còn nếu như bệnh nhân mà chúng ta không tái thông được, tức là TC2A trở lên, hay T1, T2A, thì chắc chắn chúng ta sẽ giữ huyết áp theo đúng guideline. Tôi muốn hỏi giáo sư Craig đó là trong cái nghiên cứu này, cái kết quả nghiên cứu này có nhìn đến cái subgroup ở cái nhóm mối lứa tương quan giữa việc mình hạ áp với cái nhóm mà đạt tỷ lệ tái thông từ TC2B trở lên hay không?
Yes, that's a very good question. That was pre-specified in our analysis, and I know that forest plot of the subgroups was a little difficult to see, but it did show that there was more harm in the 2B-C group, so the one with incomplete reperfusion. But because the numbers were small, most I think it was 90%, most achieved ETICI 3. So the number with incomplete reperfusion was quite small, and therefore the numbers did not allow for clear statistical difference. But it is a cause of concern. I think what we should do with Enchanter 2 MT is I haven't discussed this with you, Mark, but I just wonder whether not just doing a simple stratification, but we should actually do a double randomization according to TICI 2B-C versus 3, and look at that separately, which would mean if any harm arises there, you could stop that arm of the trial and keep the other arm going. I'm sure that is the most clear potential subgroup where dropping the blood pressure systemically may impact on that reperfusion through incomplete reperfusion.
David the Guru on TICI scores.
Yeah, so I wrote on the ETICI score. I didn't create it because it's nothing new. But
you just developed the 2C category.
No, 2C existed, but ETICI, I wrote the first paper on it, just describing the fact that there was all these gradations of the TICI scoring. The first issue that comes up again and again in studies is that site adjudicated, non-core lab adjudicated TICIs are pretty poor. In Get With the Guidelines in the United States, people tell you that the capital G in Get With the Guidelines stands for garbage, because it's the 3, everybody just puts down a 3 and says it is a 3, and it's not adjudicated. The other issue is when you get to the gradations, the differences matter. So, Craig, I wasn't a reviewer, so you got spared this, but the devil's in the details in terms of the degree of reperfusion. Not that I know the answer to the blood pressure effect with these gradations. I think it's incredibly important to know that exactly as you've alluded to. But from the outset, you looked at only patients with successful reperfusion above a 2B50, so 50% ETICI, going all the way up to 3 or 100%. You ended up with 84% that were deemed ETICI 3. So only 16% between the 50 and 99%. So what was reported as ETICI at 3 probably wasn't ETICI 3. There was probably there's not been a single recent core lab adjudicated trial that has actually had those results. Our TICI reperfusions are very good. They may be 2B67s and 2Cs, but not 3s. So 2C of 84% is a simple reflection of the fact that it was site and not core lab adjudicated. And then when you get to those gradations, I think the details are really important, because if you dig deeper before you even do the next phase of the study, I think there's a good shot that you're going to find some interesting differences there. And one of the things that has come up before is that, people say, it's not possible to do easy practical trials. We don't have the imaging. You're asking, for more. There's nothing simpler than getting your post-reperfusion TICI on an angio, because you have to literally avoid it. It's available. So I would try and get that data and look at that in detail, because that will help you not just in terms of your plans for your next phase of the study, but actually to dig into further details of the current data set that you have. I think it's a very valuable question. And as you know, Craig, multiple groups, including, the target, BP target, French group, the best trialists in the United States are trying to look at this. But again, the details of the trial methodology are absolutely critical. And when you're looking at degree of reperfusion, you need the core lab adjudicated ETICI.
Yeah, look, I completely agree. I was going to ask you the question is how much disagreement there is, because this was the direct MT trial network. These are very experienced high volume centres, and it would be interesting to know what is the agreement between...
The German stroke registry has shown that the correlation between TICI scoring based on site versus central is the correlation coefficient is barely 0.2. So it's extremely poor. And it's not just overall, it depends on how you're breaking down the TICI. So if you're looking at the 2B67, a 2B50 is abysmal nowadays. That is very rare. So it's not, I'm not saying that, that your e-TICIs are all, that the e-TICI 3s of 84% are, necessarily just sky high, and that those are really, 2B50s. They're probably not 2B50s. They're probably 2B67s and 2Cs thrown in. But that's exactly where you want to be studying the effect of blood pressure, is in those middle categories. So there's something wrong with overall it being 84% e-TICI 3. Again, site adjudicated TICIs, even by expert readers at the site, is simply not the way to look at the data. Oh, yeah, not to be overly critical, but you have the data potentially. There's no way that you don't have the data. It's the imperative, I would say, is, if my critique is, Craig, you have the data in hand, so you must analyze it.
I see that in the ETKs, it's a little bit difficult to make a precise assessment. So we just use visual assessment, or we have to use any app or anything to calculate the percent of.
Yeah, it is and it isn't, easy. It depends on, if you don't use any tool, then it's not easy because you're not used to doing it. It's not that difficult. We've shown correlations in Hermes between readers and in other studies at performance levels in terms of the various gradations, in terms of the differences between a 2B50, 2B67, and so forth, and all the gradations. So it can be done. It's not that difficult. There are differences in 2C versus 3, and clearly there are, but you can see those differences. It's not that difficult. The critical design or methodologic approach for a next phase, Craig, not retrospective. Retrospective, there's always time for science. You can always dig into the data. You absolutely will have all the data. If you have, you have beautiful follow-up in terms of the clinical data, I can assure you, you can find all the angios. There's no question about that. Then when it comes down to prospective trial design, the critical part will be in terms of randomization is how are you determining the various treatment regimens? Because if you do rely again on local interpretation, that's where it becomes methodologically difficult. So if you have, because you want to be able to, you're not going to have core lab adjudication in real time. That's the difficult challenge going forward.
Yes, and then I have a question for Mark.
Well, just one other comment. There is a simple way of doing it, though, Craig, in terms of prospectively, is pre-specifying which categories you really care about within the range to do it locally. So the local performance will be much better. Let's say if it's a 2B50, 2B67, not distinguishing 2C from 3, let's say.
Yes, question for Mark about the SCA model. I'm very interested in this. I want to ask that the team for the SCA is each of the same team like before. We just change them, or we recruit a new team for SCA model.
So the stroke capable ambulance in-hospital team are the same stroke team. It means a little bit extra calls. You get calls from the paramedics when you're on call. But the team's the same. It's just better communication. It's actually not that complicated. Funnily enough, the paramedics record multiple scores in stroke and other conditions, and often they write it down on a bit of paper, and it's not even transferred to the emergency department in most cases. The paramedics in New South Wales have 10 different scores of like pre-morbid function, so not just for stroke. So they often do one, but we never see it in the hospital. So it's just, I think it's more about enhanced communication more than anything else. But I mean, ultimately, I mean, we've been treating MI in the field pre-hospital for 15 years with Tenecteplase, or obviously an ECG is relatively straightforward to assess. In fact, you don't need a cardiologist. You've got AI for that now. But I think it'll be similar in 5 years' time with stroke, with new imaging.
Do we need the doctor?
That's a good question. Funnily enough, we could talk all day about that, because if you think about it on face value, you think, take the doctor off, it'll be a much cheaper model. In fact, the telestroke model is quite expensive, as Professor Ma will attest to. The telestroke doctors actually get paid quite well, even better in the US, but even in Australia, they're paid quite well. So it's actually probably cheaper to have fellows on board the MSU, because they're not as well paid as us, as David. You put David in a telestroke model and go broke within 12 months. So there's two ways of looking at it. And then you get into debates about how well does a stroke nurse recognise stroke mimics. I personally don't think they're very good at it, but then someone might say, well, it doesn't matter, just give the stroke mimics lysis anyway. That's a good way to show you've got a good daughter needle time. So there's all sorts of different arguments, but I guess my bottom line is that I think the big mobile stroke unit with the big CT on it's really not going to be a widely generalisable model. It's going to impact at a community-based population level, even though it's fantastic to do trials on and look at it'd be great for looking at blood pressure lowering pre-hospital and other things. But
you see the traffic in Vietnam yesterday. You think mobile stroke unit can work in Vietnam?
No.
Can I make a comment and a question? Yeah. So I am leading another trial in China of pre-hospital blood pressure lowering in the ambulance, 2 regions, one in Shanghai and the other in around Chengdu, and we use bolus in the ambulance of people who are hypertensive at retrieval, but they're fast 2 or more, so they've got to have an arm paresis. So it's we specified that because we wanted to make sure that they were true stroke. So we wanted to sort of have a group that was sort of more severe. And we're randomised about 1,500 patients. The target's 2,200. But in view of Enchanted, we asked the Data Safety Monitoring Board to look at the safety by those who presented with ischemic stroke and hemorrhage separately. And there was no signal of harm by that, and because it's China and because of the patient group, it's about a 50-50 split. So out of that 1,500, it's about 50-50 split hemorrhage and presumably large vessel strokes as well, which is reassuring because they're getting the blood pressure down to 140. So that's just another sort of comment that a 140 target looks very safe, and that's in the pre-hospital setting. But the question to Mark is that in that trial in Shanghai, Pudong, Shanghai, the average time from retrieval to hospital is 30 minutes. And in Chengdu, which is a more rural sector, the average time is 40 minutes or 45 minutes. There's not a lot of time to be doing things in the ambulance. And I just wonder how you balance off, retrieval rapidity versus interventions in that, because that's not a lot of therapeutic window in which you're going to
to help the person. I guess if you could ease up the transfer, you might gain another half an hour in the hospital. So you might be able to milk out an hour of a therapeutic window. But I'm struggling to work out what's your window of opportunity there.
I mean, having been out in the ambulance quite a lot, they actually spend quite a bit of time on site. There's actually a decent window for treatment. The CT imaging, I think, is too long. It takes 20 minutes roughly, but I do think there'll be opportunities. I mean, you can start treatment and then drive. You don't have to sit there while it's, I mean, particularly if you're going to use Tenecteplase, so you're giving it before you take off. So I think there is a window. I guess it's always going to be an issue with relatively with clinical assessment alone. But the paramedics are pretty slick, but you still sit there for quite a while. So I think there is a window in general. And even if you've got a 30-minute window, I think it's worthwhile using. Sorry, David.
I just wanted to say that one of the other gaps in terms of the treatment intervals is that we sort of forget about is, you know, with the current MSU models, like the one we have in Los Angeles, there's this whole issue about sending the team out, right? So the fastest pre-hospital model is where the patients are alerted and everybody and their cousin, again, is trying to come up with their own technology to strap people down and wear all kinds of things. Again, I say this with absolute horror as a imaging expert, but it's not going to be your traditional imaging. It's going to be all kinds of other things. It's going to be every type of brainwave thing you can measure that one hemisphere is different than the other. So, Tang, I would say that the best model, seeing the motorcycle and the moped traffic here, is now that you finally have everybody wearing helmets, Apple's AirPods, believe it or not, actually, they have the technology patented for vital sign monitoring and EEG as well. So if you can build that into the helmet and get people to wear their helmets, then when somebody drops on the street on their motorcycle, you'll know it's a stroke immediately.
Actually, have a related question. Because if you look at the MSU model, there are two components. One is actually the CT scan at the start of the treatment. The other component is transport. If you're not doing a clinical trial, the transport is actually useless for the MSU. You can actually send in a general ambulance. So maybe you said you are on a shift of like 3 hours, you cannot go off and so on. I don't know, you must have thought about that. Should we just send the MSU to assess and start treatment? For most of the patients, they can be sent in a normal ambulance to the hospital. For the others, if you need to do a trial, you send the team, and then you send the next team to take a cab to go to the MSU or something?
No, I think as I alluded to, the MSU models is not really a practical one because you're waiting on the team to get the best models where the local ambulance they always get there first. You're often 10, 20, 30 minutes before the MSU. So what I was alluding to before is that particularly for thrombectomy patients, you take them to the wrong centre that without thrombectomy, then you've lost a minimum of an hour, usually 2 or more, depending where you are. So yeah, definitely waiting for the team, the experts to all come out is not really a practical model. The one thing I think that we've sort of overlooked is that it's actually really good training for the neurology residents to go out on the ambulance and actually see patients in the field. It's quite different to in the hospital, even different to the emergency department. That's one thing that I feel a bit sorry about when we're taking our trainees off the ambulance, because they do learn stuff that they don't see in the hospital. But that's a philosophical thing, I guess. But yeah, I think we need to change the whole pre-hospital model of care, but it'll be different in different countries.
The time's up now. Again, thank you very much, speakers. Thank you very much for joining us this year. Hope to get you in the next few years. Một lần nữa xin đại diện Hội Đột Quỵ Thành phố Hồ Chí Minh xin trân trọng cảm ơn các đồng nghiệp đã có mặt cho đến tận giờ này. Sự có mặt của đồng nghiệp luôn luôn là cái niềm động lực cho tôi để có thể thực hiện những cái cuộc hội thảo sắp tới. Mong tiếp tục được sự đồng hành với các bạn để chúng ta mong muốn xây dựng một cái đội ngũ đột quỵ và bác sĩ điều dưỡng chăm sóc đột quỵ ngày càng tốt hơn ở Việt Nam. Xin một lần nữa cảm ơn, xin trân trọng.